Right. Well, I make it 9:30. So welcome. Just a reminder, recording has started of the meeting. Good to see everybody. We have apologies, I think, only from Chris Hodgson for today. And I just wanted to note new appointments to the board. Miranda has kindly agreed to take the Wellbeing Guardian role because that sits alongside her role as chair of the People and OD Committee. And Amanda Federo has taken on the non-exec lead role for maternity, which is particularly important given the Ockenden report that we're looking at later in the meeting. So thank you both for volunteering to do that. Then I think there are no declarations of interest over and above those already notified. So let's go straight to the minutes. First of all, are people content that they are an accurate record? And I will take silence.
There's a few minor points, but I'll happily pick up at Pete. It's nothing material.
Okay, thank you. We haven't recorded any specific matters arising, but there's an opportunity for anybody to raise any matters that doesn't appear elsewhere on the agenda. Jackie?
Thanks, Chair. There was just feedback on potential outputs from the 111 first. So I haven't received anything, but I just wondered if where's that going to go? That was on page 9 of the minutes.
Okay.
Page 6 if you're doing it not on the iPads.
Thanks, Jackie. Anybody want to just pick that up?
No.
No.
If
Tara?
we are looking at the start of phase 2 of 111 first commencing this Friday, so I'm quite happy to bring back a summary report next month if that's okay for everybody. I'll just add that into my verbal update.
Thank you.
Sounds good.
Thank you.
Okay, so minutes are agreed, no other matters arising. Let's move on to the feedback from committees. We've got written reports now for all of them, but audit, Nikki, anything to add to the detailed report that exists?
Thank you, Steve. Nothing really to add. I think the only area that's worthy of discussion is around BAF, but we will pick that up in due course.
Okay.
Thank you.
Thanks. Yeah, similarly with finance, I think I mean, it seems to me that despite kind of considerable in-year pressures, we are aiming for break even again. That would be a second successive year if we're able to achieve that, and you know, we shouldn't underestimate the significance of that in the sort of history of the trust, and I think, as the note indicates, lots of ambiguities around particularly 21-22 that are still to be addressed from external sources that we still need to tackle. But otherwise, I think that's reasonably straightforward, and I'll take strategy as well. Obviously, as the note indicates, we're continuing the work on 5-year plan. We looked at BFF assurance. We spent quite a lot of time on frailty. Obviously, great progress has been made over recent times with frailty. It's a key service area for us. We've got more to do, and I think everybody wants to go further and faster with that with that work, and we looked at the preparation that we're going to need to do the business planning for next year, notwithstanding all of the uncertainties and ambiguities that are around. But otherwise, nothing to add on strategy. People and OD, Miranda?
No, there's nothing to add to the summary. It was we've refocused our meetings because of operational pressures due to COVID. So it was a very focused meeting, concentrating on the topics we've agreed. I think some of the aspects of the pressures on workforce as a result of operational pressures at the moment will come out, and we can discuss during the integrated performance report.
Great.
Yeah, nothing to add.
Thanks. I've overlooked two hands up, so my apologies. Damien first.
So thank you, Steve. Just for accuracy, and I'll go through it in the F&I section or the finance section. I would say that we're at the moment targeting about a 2 million deficit plus a further risk of about 4.5–5 million on non-NHS income. So I don't think it's quite accurate to say that we're forecasting break even at the moment.
It would be good though, wouldn't it?
It would be good. Sorry. Yes.
So yeah. Okay. Jackie, you had your hand up, or was that from before? Okay. All right. Thank you. And Jackie, then to you on quality and safety. Anything to add to the written report?
I think the bullet points are self-explanatory, but I would really like to emphasise the third from the bottom. Given the pandemic, we're delivering care in changing parameters, and that the committee and I feel that we are operating in a possible higher risk environment, and we need to acknowledge what is reasonable and what we are expecting of our staff and what level of protection and support we are giving them, because the last couple of weeks and months have been extraordinarily hard, and I think we need to be very clear on to what level we're holding people to account.
Yeah. Thanks, Jackie. Vicky, you and I, we kind of informally touched on this last week, didn't we, when we were catching up? I mean, it's been difficult. It's been difficult for clinical staff stretching what they feel is reasonable. Is it worth saying a bit more about that and how staff are feeling, and what, to echo Jackie's point, what we're trying to do to both support people and to give them reassurance that there's backing from the senior leadership team, backing from the board?
Certainly, Chair. So I think the last 2 months in particular, I mean, it's been a very difficult year for everybody, but the last 2 months in particular for ESHT have been extraordinarily difficult, I think it's fair to say. And I mean, I'm sure, in his report, Steve will talk more about the impact on our staff and all of the support that's in place and will continue to be in place going forward. So I think when I've spoken to staff, when I've been out clinically, they've been very aware of how difficult it's been, and they've been very aware of the inevitable impact on quality. I'm sure we'll talk more as we go through about COVID and the impact on the workforce. But I think given the last 2 months and the significant surge and the huge impact on staffing, I think despite everyone's absolute best efforts, it would be impossible for there not to be an impact. And I think what I would say is that everybody has absolutely gone above and beyond every day, every week, to do absolutely everything they could to provide the best possible care. But that has been very difficult. And I think staff have recognised that despite all of their best efforts, it's just simply not been possible all of the time to maintain the standards that we usually do. And I think that's very difficult for staff, personally, to have to to try and accept that. And I think they do. They have worried, you know, personally and professionally, not just for themselves, but for patients and for their colleagues. And I think they've asked that that there is an understanding about how difficult it's been, and a recognition of that. And I think there absolutely is. I think we all absolutely recognise the extraordinary circumstances that they've been delivering care in, and that's all staff across the board. That isn't just our registered healthcare staff. That is all staff. So I have assured them and said that the board absolutely understand how difficult the last couple of months in particular have been, and that there is certainly no intention whatsoever to deliver care, you know, below the standard that we would normally deliver. But I think people have done a phenomenal job, and I'm hugely grateful and hugely proud, actually, of the staff.
Yeah, thanks, Vicky. I mean, recognising how difficult it is, we'd want them to know, wouldn't we? How, I mean, to use a colloquialism, that we've got their back, that they're not on their own. Yeah. But what about medical staff, David? Would the same? I mean, I'm assuming it's exactly the same for medical colleagues.
Yes, to some extent. I mean, I think it would be fair to say that the nursing staff have borne the brunt of the extreme shortages, and have borne the brunt of the issues on the wards. But there are certain groups of medical staff who have been amazing. In particular, the respiratory physicians who have been running. They've been doing a 1 in 4 on one site and a 1 in 3 on the other site, doing every weekend, often looking after 8 patients on CPAP on the ward, and also the intensivists, within the intensivists, I'm including a lot of anaesthetists who have stepped into the breach to increase the support for the intensive care units, who've also been on surge rotas and have worked phenomenally hard, and have had a sort of beefed up outreach team where they've been going out and working closely with the respiratory physicians and other physicians, looking at patients and deciding where they're best managed. And then the junior medical staff who have been redeployed outside of their normal areas. Medicine has been looking after something like 100 more patients than it would normally do. And so other groups such as the obs and gynae, paediatrics have given up their junior staff who've gone to work in medicine, and they've done a phenomenal job. And I've had lots of plaudits, particularly for the paediatric juniors who've been a revelation working on the medical wards. So they've been fantastic. But I don't think we can get away from the fact that some of the nurses where we've been really short-staffed have had the hardest time of all, I think.
Yeah. So I think really that from the committee's point of view, and I'm not sure if it's for here or that committee, it was whether or not we review where our target standards are, rather than show a sea of red to anybody. Do we accept for a period of time that some might not be 90%, it might be 80% compliance, and it's more explicitly doing that. So when we are reporting, we are not constantly showing people that they're failing and impossible to reach standards.
Jo?
So I do think it's worth a wider conversation at the committee. I think it's really important that we remember what normal is and what our standards are. I think if there is so it definitely applies, and Tara will pick that up in her bit when we talk about recovery of performance standards. I think it's reasonable we've got a trajectory. So what might be helpful is that we retain the standard, but we have recovery trajectories that we also report against. But I wouldn't want to lose what we expect is our standard position, really.
Yeah, no, agreed.
Yeah, it's a good way to put it, I think, Jo. Damien?
Just on performance standards, it's useful to note that nationally they've withdrawn any penalties for the 1900 standard, for not achieving the 1900 standard.
Good. That's very good. Okay. So I think that Was that all from Q&S, Jackie? That was a that was a fairly lengthy Q&S report back, wasn't it? So that takes us to the BAF, Lynette.
Thanks, Steve. Hopefully it's self-explanatory, but in summary, as you'll see, some of the risks have moved in a direction we wouldn't want them to go, but it's the nature of the situation we're in at the moment. So BAF2, which is around COVID, and BAF3, which is our access standards, have moved from 16 to 20, and BAF1, which is quality and safety, has moved from 9 to 12. Been having discussion with Vicky. I mean, arguably, the BAF is written at a point in time, so things change on a weekly basis. BAF1 could be higher, could be 16, but a lot of that risk is around our controls and our governance framework and our assurance processes. And we actually, despite things being challenging, I think we can still evidence that a lot of our processes are still in place and still operating. So it's one that could go either way, but I'm just flagging that we're having that discussion and keeping our eye on it. Probably by the time I come to rewrite the BAF, it'll be at 12 anyway. So, but we can look at that. It's been through the committees, and at audit we discussed about BAF5 protecting our staff, and although it touches on, initially that risk went on there when we had the HSE inspections and recommendations around improving violence and aggression. And then it sort of morphed a bit into the wider protecting our staff, so lone working. There's a little bit about protecting our staff in COVID with PPE on there and the risk assessments. But at audit, we talked about whether that could be strengthened and whether there should be more of a more mention of how we're protecting staff and the number of staff that are off sick at the moment, either because of COVID related or isolating or other illness. So we probably need to look at that one and take it through pod, I would suggest. But I'll discuss that with Steve. He's got his hand up anyway. But outside of that, I'm happy to take any questions on the BAF.
Okay, thanks, Lynette. Steve?
Yeah, I think just to build on Lynette's point, Chair, I think we can expect to see a sort of a slight change to the sustainable workforce and protecting our staff focus as we go forward, which is actually moving more towards sort of retention and looking after staff as we move beyond where we currently are. And I think we can expect to see some risks, certainly one significant risk starting to appear, and that we're going to need to manage around that, which is actually about how we do look after and how we retain staff post the experience they've had. So I just wanted to really echo Lynette's point and said that I think this is going to morph into a new set of risks which are post the current pressures that we're under, and it's going to be important that we do discuss those at pod and at board.
Yeah, thanks, Steve. Nikki.
Thank you, Chair. I think the other thing I just wanted to flag that we discussed in audit was that we've probably passed this point now, hopefully, given where we are with this surge, but we started to think about how in circumstances that were similar another time, it might be possible to simply flag where some of the controls were not operating on a temporary basis, so that we could see where some of those risk mitigations were perhaps not quite as effective as they ordinarily might be.
Okay, thanks, Nikki. Jackie?
Just 3 points. On BAF2, I thought it would be important, maybe we have a milestone for restore and then recover, because something Joe said a while ago that really resonated with me, that we have to restore our services before we can then recover. So I just wonder, because it's sort of as a catch-all, we perhaps split them out so we can see when we are restarting. And then under BAF4, we've got a new risk on chemistry, but I didn't see any specific actions to mitigate that specific risk. Whether or not the general actions cover that, I'm not sure. And the last one was in BAF8, whether or not the timetable for our BFF change or possible change, does that do anything to the risk and to any of our actions? So those was me three.
So the chemistry risk, obviously there'll be actions related to that on the risk register itself. So that's why it's captured there, and we sort of capture it in a generic action around recruitment. So we wouldn't specifically always pick up every single action related to the new risk. I think it's just flagging that it's there. Okay. And then BAF 8, I'll just have a look at. Yeah, we probably need to review that, don't we? I'll make myself a note, Jackie, and just we'll look at that one.
Thanks. Vicky?
I'll pick it up with Lynette, Chair, but we have had a brief conversation about BAF 1, and Lynette's right. It might feel that we're kind of past this most recent surge, but I was just keen that we in some way captured the challenges that it presented and the impact, even if it's, you know, retrospectively. So but I'll pick that up with Lynette and probably a discussion with Jackie and in the Quality Committee. Okay,
thank you. Nikki, is your hand up from before? Yeah. Good. Okay. So thanks for that. Thanks for that, Lynette. Shall we move on then to item 7 and the Chief Exec's report, Jo?
Yeah, thank you. So I suppose the first thing I want to say, and we've touched on some of this already, but I think the first thing I just wanted to recognise is a really big thank you to all of our staff. They really have. It's not just the second wave. This has been a year now, and I know staff go over and above normally, but really I think everybody has superseded themselves and they've gone way over and above, but particularly over the second wave. I just want to start with a bit of sad news, really. So we are mourning the loss of 3 staff members over recent weeks. Caroline, who was a much beloved member of the outpatients department, Michael, who was a dedicated and much respected member of our housekeeping team, and Naomi, who was a really dedicated critical care nurse. And I think it's really important that we recognise, with great sadness, both for our staff, who were their friends and colleagues, but also condolences to their family. And we just wanted to particularly note that in our public board meeting.
Thank you, Jo.
What we have seen, our teams have been so compassionate for all of our patients, and actually amongst themselves as well, because as we've already touched on, actually it's been really difficult for staff. You know, we've seen things that we wouldn't normally see, and really, you know, high numbers of very sick patients, and sadly not all of those survive. So just wanted to really note that, and I think we've shared some of these offline, but some of the stories that we've seen and heard really have brought a tear to our eye about how people have gone over and above to support their families and those patients involved. So the other thing we want to do is obviously make sure that we don't forget our non-clinical teams. Our clinical teams are front-facing, but actually a lot of the non-clinical teams are on the front line as well. Many of the back office teams have been redeployed. And as we'll pick up, we've had high levels of absence, either for isolating or sickness. So people have been really flexible in moving around, moving their work hours, moving work days, and covering colleagues as well. So I just really wanted to pay dividends to absolutely everybody. I also, and Chris isn't here today, but wanted to pick out the facilities team as well. And Steve will pick up on some of the workforce and the wellbeing elements. But the facilities team have been supporting wards with daily meals and the snack boxes and extra cleaning, and they've been really busier than they would normally be. But we had a big discussion at execs the other day, because what we recognise is that the pressures over time will have taken their toll on people, whether they've recognised that yet or not. It will take its toll. It's a year of really hard times. So I know that Steve will pick up on some of the wellbeing stuff. I thought I'd just help set the scene, and we've done a little bit of this already. So people will be aware that East Sussex was one of the highest community rates for COVID in the country, and obviously that's had a knock on to both our, the public, our staff, most of who live locally, but obviously our admissions with high numbers being affected by COVID. So just to give you a flavour of what that looks like. So in our last peak, if you add up our positive cases, our treated positive and our suspected, we had in acute services 75 cases. At the peak, we've had around just under 450, plus another 60 to 70 in our community hospitals as well. So we're talking about a good 5 times the first wave. And I think it's really important to understand that. We should just note, and many of you were already aware, that Bexhill was operating as a designated COVID discharge area, so that we could move patients out for their isolation period before we moved them on into care homes. So that's why there's been higher numbers there. ITU's been operating sort of between 50 and 80% above what they would normally do, but not just in one single area. So they're working across 2 or 3 clinical areas. So they've been very challenged, as we've heard, probably quite widely on a national level. So I wanted to pay particular respect to them, but as we have with all clinical and non-clinical teams. Tara will pick up a bit more, but we have continued our cancer services, but there have been some challenges where we've required post-op ITU, and that has caused some delays. We've continued to have weekly staff webinars, which myself and other colleagues, particularly Steve, Tara, Vicky, and David have been doing a live webinar and answering live questions. The feedback is that that's gone down really well. We'll continue to do that all the time that staff feel that that's right for them as well. However, it has been tricky, and it really has been. But on a positive note, the community cases are coming down and our inpatient numbers are coming down. We've about halved over the last couple of weeks. And going back to the point of normality, 200 inpatients plus our community inpatients as well does not mean that's normal, and it is still significantly higher than that peak of 75. So I don't want to think that we are out of this at all, but for those living and breathing it, it feels 100 times better. And Tara will pick up some of what that really looks like. We've seen a lot of staff coming back to work, and it feels better. But as I say, we just need to remember what normal is, and we're way off that at the moment. We will be looking at recovery plans, and to pick up on Jackie's point, restore and recover. And I know Tara will pick a little bit more up around that. And just a little bit more shout out for the estates team. So we have opened Devonshire ward, which was meant to be our decant ward for our fire compartmentalisation, and it will be in due course. But that's allowed us to open up an additional ward at Eastbourne. There's some additional work. There's work to open Glynde ward, which will allow us to give us our decant ward again at Eastbourne. We opened Firwood, which was a temporary unit in Eastbourne to help facilitate discharges. So the estates team have very much been integral with the operational teams, and others may pick that up in their updates because it was quite phenomenal what we did. So I think probably between Steve and Tara, they may well pick that up as well. There's work due to start at Eastbourne and Conquest in the emergency departments, but there was some work before Christmas at Eastbourne. The new modular building for the creche has been is up and running, and the Conquest IT training and switchboard, there's new buildings and have been relocated. So actually, all through all of this, everybody has we've been responding to the COVID pandemic, but where we have had the ability, we are still continuing to do things as business as usual. I know Richard will pick up a little bit about business planning, but we have to still build in the business as usual and that strategic look forward. And as we're getting headspace, we're better able to do that at the moment. And as Vicky will pick up, and David, we've managed to keep our core governance running, which has been really important so that we do know how we're doing all the way through this. So I'll probably stop there unless anyone's got any questions. I think most of it will get picked up through the IPR updates.
Great. Thanks very much, Jo. Questions from colleagues? Amanda.
Jo, thank you, and thank you to everybody for what has been an extraordinary job during extraordinary times. I just wondered, in your weekly briefings with staff, and I think that's a great thing to do, keep in contact, have you been surprised by any of their feelings? Do you think that our BAF and our risk register really pick up all the issues that are pertinent to our staff today? And is there anything that you want to bring to the attention of the board that has surprised you, I suppose, in those conversations?
I think not really. I think sort of reading through the BAF and just doing that sort of fresh sense check as we do, I think everything's there. I have to say most of the questions have been around vaccination. Quite a lot of questions have been vaccination. Quite a lot are still around PPE. And it's great because people just don't, every single question that's been asked of us, we publish. We haven't, we've published every single question. That's sort of, there's quite a lot about well-being that's been picked up. But they tend to be the same themes probably in terms of questions, and the information we're giving is very much about how we are doing as a trust and how we're doing as a system around the pandemic response. And how we're doing particularly, well, picking up again the same things. It's the vaccines, it's the well-being, it's the PPE, and we cover off a number of stats as well. So I don't think there's anything that's flagging to me that I think we haven't picked up. And I think just to pay dividends to all the execs as well, the majority are out there talking to staff every day. So I think we've got that real walk the floor sense as well. And I'm not, and I talk to everybody every day as well. I'm not feeling there's anything we've missed either on the risk register or the flat or the BAF. And just for assurance as well, we have an IMT, an incident management team meeting that Tara or I chair every day. It's still running every day, and it has its own risk register, which links into obviously the trust risk register and the BAF. So it's fairly dynamic, and we review that as a senior leadership team every week.
Thank you, Jo. Thank you.
Right.
Thanks, Jo. So no other questions for Jo. I suppose the only thing I would say, Jo, is that obviously the reduction in the number of inpatients, I mean, is hugely encouraging, isn't it? As you say, I must be honest, I've been slightly surprised at the pace of reduction, and I don't know whether that's just me. I was fearing a much more elongated period of reduction, but if we carry on at the rate of reduction, that would be extremely encouraging indeed, wouldn't it?
Yeah, so there has been some modelling, and I might, if you've just got 2 minutes, just bring in Tara, because Tara's been looking into the silver. So right. Tara, do you want to just pick up the modelling? And when we think, I'm going to use the word normal, which is terrible, but around the occupancy and just what the Sussex-wide modelling says for us.
Yes, very high level. In fact, there was an update on silver this morning. The modelling up until this morning was showing that actually Eastbourne's return to normal would be April the 11th and Conquest would be April the 6th. However, we have seen such a dramatic or a bigger decrease, especially at the Conquest site, than the modelling had originally predicted. So they're going to remodel that today to show when we get back down to the 5%. So we are expecting that to come forward. By how many weeks, I don't know. But it's anticipated that actually the Conquest site will return to a normal level earlier than Eastbourne, just based on the COVID numbers. So we were expecting and working to the beginning of April as being the time for the restart into recovery, but we're probably going to be looking at bringing that forward by a couple of weeks and maybe having to do different for different sites. But I think as an organisation, we can absolutely manage that.
Thanks, Tara. David.
Just to say, Chair, that the although it is falling much more rapidly than the modelling suggested, some of that fall is because patients who've been in for longer than 14 days and no longer have symptoms of COVID are stepped down from the COVID list, and we're calling them blue areas just to make it clear where they've come from. The national rules say they can go back into green, but we're cohorting them together because some of these patients are waiting for packages of care in care homes and can't leave the hospital at the moment. But the rule is that they come off the active COVID list after 14 days if they're no longer symptomatic. But they're still in hospital, some of those patients. So there is actually, I can't give you the exact figure, but there is a cohort of blue patients on top of that number, which are still blocking beds because we're struggling to get them out into care homes.
But those patients are ready for discharge.
They are ready for discharge. We're calling it that they're COVID recovered is the technical term we're using for them.
Okay, that's very helpful. Thank you, Vicky.
Just to say, I think things are definitely improving, but as we know, there is a lag for us in terms of how kind of quickly we feel the benefit, if you like, of that reduction in the population. But also, and I'll talk more about the new variant, that I think the impact of the new variant has been very different this time from the first wave. Certainly, we've seen that in patients in terms of severity, but also in our staff. So it may be that the length of stay and the complexity for patients is a little bit different this time around, but it's definitely positive news and heading in the right direction.
Thank you. Yeah, good news. A long way from being normal, but we take all the good news we can get, I think, don't we? That's Amanda. No, not
Thank
Amanda.
you, Chair. No, thank you, Chair. I'm sure it will be covered in the rest of the agenda, but I'd like to, by the end of the board meeting, understand how we're going to, as a board, balance the need to recover services with the need to give our staff the time and energy and focus that they deserve. And I think we will touch on that in the IPR, but I would like a sense of how, as a board, we're going to oversee that and make sure that we strive to get the right balance.
Thanks, Amanda. Before I come to Karen, this is something I know that you've been thinking a lot about, Jo. Is your hand up in order to respond specifically?
It was just, just a very brief response, and Tara may well cover in her bit. I think it's recognised, just to say that it's recognised within the Trust, it's recognised within Sussex and the region and nationally. I think the challenge is how we do that. Tara and I have had some conversations that we haven't necessarily run past others yet, but we're very much aware we need to be able to let people take annual leave, have a break, just breathe really before we go full pelt on recovery, which is why I think we're trying to use the words restart and then recovery being something different. But Tara may well pick up in her bit as well, but we're very much aware of that, Amanda.
Thanks, Jo. Karen.
Yes, just to quickly go back to the blue patients, what kind of numbers are we talking about? Because you've talked about, you know, the numbers about halving into coming down from the 400 to 200, and that sounds great for staff in terms of less patient load. But if we've still got, I don't know, 100 in blue, then actually, while the patient load may have shifted, it's still not eased up nearly as much as what one might expect.
So if I may, I think there's 2 points in there. One is the COVID numbers. So the COVID positive patients that we're managing is real, and that is 200. I think that the blue patients are, as we said, they're 14 days post, and if they're well enough, they move into the blue bit. What I think it might be worth doing is Tara picking this up in her bit around the medically ready for discharge, because some of those fit into that category and some of them don't. but we still would look at them in the sort of round of those that are ready to leave the hospital and what she's doing around that. So it might be worth, Karen, if it's okay, leaving that for Tara to pick up in her bit, if that's okay.
Thanks, Joe. Jackie.
So just a point, picking up on Tara, are we going to sort of have a celebratory, right, we're back to normal now, it's like our own VE day or something, so we don't just drift into normal, we explicitly end COVID or it's business as usual and some of what we do is permanently changed, but do we celebrate the fact that we're through it or some way, because we could kind of just drift along if we're not careful.
Tara, VE Day celebrations?
I think that would be quite difficult because we have to try and pick a day. But what we are doing, Jackie, is absolutely celebrating everything that we can, and we are picking that up. I'll pick up in my speak in a little while around our improvement in our 4-hour performance, and we are recognising that with the teams. We are encouraging leave. We are doing some really strange things to keep morale up. I will say it, Joe, that there is a farm that does actually bring goats into Zoom meetings, and it's just to lighten the mood. And we did that at a team meeting, an operational site meeting last week, and it was unknown to everyone, and it was literally just to lighten the mood and to celebrate and to let people know that it's not all about COVID. So we will try and do the best, Jackie, that we can. But I think I would be very, very scared to put my name against a day to say that COVID is finished, because I think Boris might come and finally hunt me down. But we are finished
because it's going to be with us forever. But
yeah.
the trust is now operating as it used to, or as we need to, just to so we mark that it's now business as usual and not something odd.
We are looking and working with staff for suggestions through the welfare teams, etc., on how we've all got our little ESHT COVID 2020. What do we do for 2021? So we are working with the staff to actually ask them really how they'd like to mark the occasion. So I think yes is the answer, whether it be a full VE Day celebration, but we will do something.
Thank you, Tara. Damien, did you want to talk about therapy goats?
No, I didn't actually, but in support of Tara's point, we're already working on contracts for next year that start on a block contract basis. I mean, the initial conversation was around at least 3 months will be a block contract basis. So I do agree, you know, this isn't going to be a clean VE Day, COVID is over. At a minimum, there will be some impact of COVID during next year.
Thanks, Damien. Joe?
I suppose just to say, I think if we take Jackie's point of how do we celebrate, I think we've talked a little bit about that. I think what's important is how we, and if celebrate's possibly not the right word, because I think, you know, as we've already said, that others may not see it as a celebratory, but we need to be able to mark a point, you know, at a week. What we recognise as well is that, and it will come up through the rest of the meeting, some things will restart and restore way before others, even weeks before others. So I think Tara's right, we celebrate everything as we go along. I think the question is, how as a trust do we recognise the staff, and maybe we have a recognition week or something like that, rather, and that might be a way forward. So we'll take that away as execs and have a look at how we can do that.
Great, thank you, Joe. Right, thanks everybody. Shall we move on to agenda item 8? A very significant piece of work for us around the Ockenden review. We've got Emma and Dexter with us. Emma, are you leading us off?
Sure, yeah. I'll take the report as read, but I've just kind of pulled together a few overview points just to go through. So the report was written by Donna Ockenden, who's a midwife and maternity leader of services and an external consultant, and it was commissioned by Jeremy Hunt in 2017. about Shrewsbury and Telford NHS Trust in response to a high level of complaints from families. It started off looking at 23 cases, and very quickly, when the media attention was brought to the report, escalated to a total of 1,862 cases that will be reviewed in total, but this report is just talking about 250 cases. They found one of the findings in the trust was very frequent change of senior leadership and board leadership within the trust, and a loss of organisational memory. The problems at the trust were often seen as historical rather than current. There was poor visibility throughout the trust and region around the issues within the services. They had a high number of maternal deaths and perinatal morbidity and mortality, so deaths of babies in pregnancy, labour and in the early neonatal period. So what the result of the report and the recommendations of the report were some very local actions for the trust concerned and immediate and essential actions for all trusts nationally. And there seemed to be a need for structural change locally, regionally and nationally. There's been many reports into maternity services over the years, and the findings were that any recommendations from those reports not all had been implemented, and had they been, some of the deaths in Shrewsbury may have been prevented. There's also some criticism of regulatory bodies, the CQC, local CCG and the supervisory authority, which is no longer in place. It was removed from statute, but at the time it was. There's a lot of political interest in this report. There were very tight timeframes for turning round response to the report. And the requests are for a change in governance process to increase the visibility of maternity services, both within trusts and regionally and nationally ultimately. We do believe in our trust that we have a very safe service, a very kind and high quality service. We have areas of improvement that we know about and are working on. We have a motivated workforce who feel supported in their workplace in the majority. We do engage with all the national initiatives that are out there. There's many national safety initiatives for maternity care, and we're engaged and progressing all of them. We've got a good safety record. We've got good recruitment and retention. There are issues around medical retention, recruitment. That is a national issue, and we're sort of impacted by that as well. But within midwifery recruitment, we're in a really good place. We're leading in our region with regards to the Better Births recommendations, and we've fully implemented the Saving Babies' Lives care bundle really successfully. We're very fortunate within our trust that Adrian and now Jo have been chair of our local maternity system, so they really understand what the maternity transformation programme is all about and what we're trying to achieve, both with quality, provision and safety. We do look at all national reports that have come out, and as Jo said earlier, there's been 15 since October that have come out, various national reports that we do a multidisciplinary benchmarking process against, and look at the recommendations and action plan if we don't already have those recommendations in place. So we have a really tight process around that. We recently had a governance peer review from another head of midwifery at a local trust, and we're reviewed very positively. We're looking at improving our IT systems, and unfortunately, we're implementing a new IT system, which unfortunately has been delayed a couple of times due to COVID and difficulties with training, but that's coming in the summer. I believe we have a really open and transparent relationship with board, and feel very supported by the board. We were very supported in our maternity midwifery uplift, so to enable us to set up now 4 continuity of carer teams, and we're already seeing improved outcomes from those teams. We do have some areas for improvement, so we know that we need to do some more work around assurance. So we believe that we've got most of the recommendations in place already, but it's the assurance of those recommendations being embedded in practice that takes an awful lot of time, because we're a paper-based service, so all women carry their own notes. So it means we can't just pull data from an IT system. It means trawling through handheld notes, so that's very time consuming. It will improve once we get the new system in place, but assurance audits are difficult, so we're looking at recruiting into an audit post to try and improve that. As you're aware, we have issues with the state on both sites and in the community that need improvement for our quality of service. We need to have a look at our maternity website, our external maternity website, and make some improvements around that. There are some low-level cultural issues, relationship, falling out, but very low level, and think something that we've been working on with the organisational development team, and it's not an issue, not a big issue. We don't have any safety concerns around that, but we don't want it to get to be a big issue. We need to look at the SI reporting process within the trust and the frequency of reporting to board. And as I said earlier, medical recruitment is a bit of an issue. But that's a very brief overview.
Great. Thanks very much, Emma. Dexter, was there anything you wanted to add?
Yes, thanks for inviting us. So just to extend a bit on the assurance, so I wouldn't say that we're ahead of the curve, but we're pretty much in step with a lot of the recommendations and a lot of the different recommendations from different bodies that come out. However, as Emma mentioned, that assurance aspect, and that's where we, we're able, provide assurance that we haven't only embedded some of these recommendations, but they're sustainable. We've been able to mitigate that by the fact that thankfully we have a low level, and I mean numerically low level of adverse outcomes. So even though this is paper-based, we are able to review those and escalate and provide assurance to the board. With respect to the medical workforce, we do need to be continually proactive with this, because the pool for recruitment nationally is shrink, has shrunk and is continually to shrink. And this is even before Brexit. European doctors were, we've had a slower migration of those, and therefore also non-EU, that group has also shrunk. So we have to be a bit innovative to retain those we have, and also to recruit. So we can't take our eye off with those. Yeah. And important for us is we have survived, like with most teams, with quite strong individuals championing causes. We're much better than that. We're much better now, I would say, than we were maybe 6-7 years ago. But we need to continually move to where we have full teams, and it's system-based rather than relying on individuals. But I agree with Emma that we think we are in step with most of these recommendations, but the continued relationship we have with the board will be welcomed.
Yeah, thanks, Dexter. I've got a number of hands up. Just before I go to everybody, Vicky, is there anything you wanted to add from your point of view? And then I'm going to come first to Amanda as the new NED for maternity.
No, I think just huge thanks to Emma and Dexter and all of the teams.
Absolutely.
It was a big ask. I think we were in the midst of a phenomenal surge in December. So, huge thanks to the team for finding the space and the time to do this, and to do it properly. I think, none of us wanted to just kind of meet an initial deadline. I tried to be as available as I can to Emma and Dexter and the teams as the exec lead for maternity and neonatal safety. And I think we have a good system in place. I hope and think that they feel they can access me or any of the execs, really, and they do. But it's fantastic to now have Amanda support as our non-exec champion as well. So just thanks to the team. They're doing a phenomenal job.
Great. Thank you, Vicky. Amanda, I know you've only been our NED maternity lead for 2 weeks, but anything you wanted to add?
Yeah, a few things, Steve, if I could. Thank you, Dexter, and thank you, Emma. You have done a tremendous job on responding to the Uppingdon report in a meaningful way and also in a speedy way. And I think the meaningful element is something that we need to stress. This is not just another report on maternity services. This needs to be the transformational, sustainable review of maternity services that I know this board would want. I think it's clear from the Ockenden review and the associated job description for the non-executive board safety champion that there is a potential for a confusion of roles. So we have been clear about, with Lynette, myself and Vicky and Emma, about the advantage of having a non-executive director scrutiny, and I think it's fair to say that still needs to be worked through. So we have put regular sessions in the diary monthly to make sure that that is clear and that I can seek assurance. But it's really also extremely important that we make sure that our governance processes in maternity align to the Quality and Safety Committee reporting to the board are well utilised and also meet the Ockenden requirements. So there is some work to do in terms of that, and Lynette's on that agenda. There's considerations, other considerations that we'll talk and are actually highlighted in the report. But I just wanted to give the board the first bit of assurance that I am absolutely assured that this trust has responded extremely well to the review. I think the assurance tool has been well utilised, the assessment tool, and we'll have a further discussion about that. But I do think there are some areas that we need to be constantly aware of. And at this moment in time, I can't give the board assurance that we will never have a safety incident in maternity, but I am assured that our reporting mechanisms, our transparency, and the level of scrutiny and debate that goes on in maternity governance is really, really good.
Thank you, Amanda. I'm just going to work my way now down the hands. Miranda was first, I think.
Thanks, Chair. I'd like to commend Emma and Dexter and the team for the fantastic job they've done in responding to this report. I think the content is, excellent, and also I know it's been produced under pressure. So well done for being so proactive and good about that. My issue with this is I do feel assured by what I've been reading and by listening to Amanda, but my issue and my slight worry about this is about the use of the word cannot in what the board is required to have assurance on. I don't have the wording right in front of me, but I think we are asked, and I believe this is lifted from the original report, we are asked to have assurance that, and I'm paraphrasing here, that these sorts of events cannot happen here. And I'm a little bit worried about that because it's an absolute. And the fact is that no matter how assured we are, we can't necessarily say that these things cannot happen here. And in fact, Amanda has just said she doesn't feel assured that they will never happen here. So
I've got the wording. I've got the wording.
Yeah.
So the wording is confirm that the board is confident that the assurance mechanisms within ESHT are effective and that the board is assured that poor care and avoidable deaths with no visibility or learning cannot happen. So I think it's about the visibility and learning rather than that it won't happen.
Okay, that's very helpful. Thank you.
That's an important caveat, isn't it?
It is, yes.
Otherwise, that
I don't think we can ever say it'll never happen.
It would be fake ridiculous, in fact, wouldn't it? Thinking back. Yeah. Thank you. Thanks, Miranda. Nikki.
Just to echo the others' compliments to Emma and Dexter on the comprehensiveness of the response. Just a couple of points. The first is probably reflective of my own personal experience, which is on page 5, the assessment of risk. Our response to that is quite focused on a normal pregnancy. So it talks about the sort of normal 2 occasions that people would have points of contact. I'd love to see our response be a bit more, a bit fuller, and take into account that doesn't always reflect everyone's experience of of pregnancy and antenatal care. And then on the consultant-led labour rounds piece, I wasn't clear from this document what our response is going forward, how long it will take us to address that gap, what closing the gap looks like, is it possible, etc. And maybe that's because it's too early days and we're not clear on that ourselves. But I just wanted to understand how far we are from understanding that gap and when the board might have sight of what closing it looks like. And then the final question was hopefully just a quick one, which was on the IT point. Will the new summer implementation mean that we are effectively entirely paperless and that risk is entirely mitigated, or are we going to have some sort of hybrid system in place?
Do you want me to take that one quickly?
Yeah.
So we will be essentially paperless, yes, but there are women who so there's two parts to the system. One is the system where we input our information, and every appointment, every contact will have an electronic input, which and it's immediate. So if a woman, for instance, rings our triage line in Eastbourne and then gets admitted to Hastings, they will be able to see in real time that interaction. The second part of it is that each woman will have an app on their device that they will be able to access their maternity notes. There are very few, but some women who don't have access to an electronic device, and they will still have paper-based notes. So each interaction we have with them, we will then have to print that interaction out and put into a set of handheld notes, which we will still have available. So very few women will have that, but that will still exist.
Thanks, Sarah. Dexter, was your hand up to respond to one of Nikki's questions?
Yes, concerning the consultant ward rounds. So we have a team job planning exercise this Friday, which we will address that. However, just on the sort of back of an envelope calculation, to move to that point will involve approximately 5 or 6 additional PAs of direct clinical care time, which essentially is the equivalent of another consultant. This was discussed at the LMS, and regionally, all units have the same concern. And I know from RCOG forums nationally as well. Again, this is something where we are in a good position in that for units of our size, the average from the RCOG last census, the average consultant cover is 60 hours per week, and we provide 72 hours, and we meet this new Ockenden action 5 days of the week. So it's really it's Saturday and Sunday that we need to try and determine how we will address this.
Great. Thanks, Dexter. Amanda, was your hand, is that an additional hand up? No. Karen?
Thanks, Chair. And yes, echoing the plaudits to Emma and the team for a great response. I have 3 questions. The first relates to page 3, IEA 2, listening to women. And it asks us to evidence that we have a robust mechanism for gathering service user feedback. In the response, it wasn't really clear to me what the process was and how robust it is. And I think that it's one we can take passive feedback, and I think we do that very well. And I would just like to be assured that in fact we really have a robust mechanism for actively gathering user feedback. The second one was on page 5, and that related to the risk assessments. And there it said that we were asked that there was a risk assessment completed and recorded at every contact. And then from the response, I wasn't fully assured that there was actually a risk assessment at every contact. It specified the discussion about the 36-week birthplace risk assessment, but that was like a specific instance. So again, it was this thing, is it at every single contact? And then my final one related to informed consent. And I recognise, Emma, you said, you know, the website needs some further work. Yeah. But I did go and have a quick look, and one of my concerns is that I couldn't find any information in any other languages other than English.
Yeah.
So, thank you.
Okay. So with regards to user feedback, we, as you say, we do have FFT. We have something that we give women on the ward when they come into the service, but also we're working with the Maternity Voices Partnership in being more proactive in gathering feedback. So reaching out to hard to reach groups for from BAME communities or particularly different communities, working with the service users within that group to try and improve how we do gather service user feedback. It is a long-standing problem trying to get people to engage in giving feedback in maternity services. You often get the same sort of people wanting to give feedback, and it's the people that are harder to reach that really don't come forward to give feedback. So we do need to go out and find them and try and gather their feedback more robustly. So we are working with the Maternity Voices Partnership on that. We've had some issues with that group during the pandemic, but things have certainly improved over the last couple of months, and Joe and other people have been involved in that piece of work. So things are definitely improving, and I do feel very positive about how we can move that forward. With regards to risk assessment at every contact, yes, we do at every contact. Our notes are designed in a way to support risk assessment at every contact, and discussions around place of birth and changes in risk and therefore changes in potential place of birth happens at every contact during pregnancy, and afterwards. Postnatally, the notes are such that risk assessments take place each time for mother and baby. So that does happen at every contact. And informed consent. So we have many leaflets available in other languages, but not all. And it's really quite difficult to get translated leaflets in any sort of quantity, and it's a challenge, but it's something that we are working on with the local maternity system. So it's a system response to that one, because we know that we haven't got everything in other languages. So it's a work in progress.
Great. Thanks, Emma. Miranda, is yours an additional hand up, or is that from before?
No, it's an additional hand, not an old hand.
Not an old hand.
Just going back to the point I made, and which you dealt with, which is helpful. I am still concerned about the wording of that sentence, because visibility and the other aspect are not to the fore in that sentence. The thing that is to the fore is, I'm just looking at it now, is poor care and avoidable deaths. The visibility and learning come at the end of that sentence. So I can be forgiven, I think, for having read it that way, just focused on poor care.
I lifted that straight out of the
yes.
I can't think of her name now, it's gone out of my head, but the letter that was sent by NHS England, so Amanda Pritchard letter. So that sentence is lifted directly from that letter as one of the requirements. So we can reword it, because we know what we want it to say, don't we? That we know that we can't completely avoid, but we want to make sure that there is awareness from the board if there are issues.
Yes, it's the learning and visibility that's the bit where that is important in that sentence. That's the point I'm making, and it's easy to lose sight of that as it's currently worded.
Yeah, let's reword that so the ambiguity about its meaning is removed. Amanda.
Chair, that was going to be my point, was going to suggest a phrase of wording that actually addressed it, given the conversation that we've just had. So,
thank you. Joe, did I see a hand up?
I was bouncing my hand up and down. I don't want to sort of repeat everything everyone said. I suppose what I want to just come is, I think there's looking at the board governance. We do have, sitting under the trust board, we've obviously got our our IPRs, which is done at divisional level, and then we have got the maternity board. We are there have been a number of sort of conversations and emails flying around. We will look at that maternity board, or whatever we want to call it. We're just going to review the terms of reference of that and make sure we've got appropriate visibility at wider exec. Vicky's absolutely all of those over this with Lynette, but we might just raise the profile of that. So we've got the wider executive visibility and make sure that it has the time that it needs rather than sort of bring it into the wider women's and children's and wider divisional report. But we'll have a look at that offline. But I just wanted to echo what Emma said. 15 reports in whatever that is, 4 months. It is taking a tremendous amount of time, and we need to look at how we can support Emma and Dexter and the team, because they obviously need to be running this day-to-day services as well as doing the assurance. So we're just going to have a look at all of that as well.
Right. Okay, well, let's draw that to a close. A very good report, Emma. Dexter, thank you for all that you've done, as everybody has said. I mean, this is there's a huge amount been done, but we're at the beginning of this, aren't we? There's more to go on. I know the exec team are over it. Quality and safety are onto it. We've got our new NED champion. So we'll hear more about this in due course as we make progress to meet all of the requirements. So unless there's anything anybody wants to add, Amanda.
Chair, just for the conversation, it would be helpful if we could go through the 4 recommendations at the end of the report and just make sure that we're happy to sign off those and the next steps, if that's all right.
Yes, of course it is. So can we do, so we've got confirmation that it's been reviewed. We've got assurance about the we've got confidence in the assurance mechanisms, unless anybody disagrees. The assurance process has been completed, and we've got our non-exec champion, so all confirmed.
Just the first one, the clinical quality surveillance model, which is a new dashboard. No, that's fine. It's a new dashboard, which I think is going to be a bit of trial and error, because it's a mixture of numerical and narrative data, which, if there's a lot of narrative data, might become quite cumbersome. But we want to give it a go and see how it works out. But we would think, Amanda and I were thinking maybe that was, if that's reviewed in Quality and Safety Committee, if that's acceptable.
Yeah, so that seems like absolutely the right place. So that's also confirmed. So that's great. Thank you, Emma. Thank you, Dexter. Thanks, everybody. Good stuff. Let's move on to the integrated performance report. And I'll start with you, Vicky, as usual.
Thanks, Chairman. So as always, I'm really happy to take questions. I hand over to Dr. Walker to talk about mortality. We have covered a little bit of this earlier on, but 2 things really that I would pick out of the report. A COVID update in terms of the recent surge and its impact on the workforce, and then a little bit about our COVID vaccination programme. So since the board last met on the 1st of December, as we know and we've said, we have experienced a very significant COVID surge. This is now starting to subside, and we are starting to see signs of falling prevalence and some recovery in terms of our workforce and our services. And yesterday's number of positive inpatients was down to 248. And that was from a peak, as Joe said, of about 450, not including the patients that we refer to as treat as positive. December and January have been incredibly difficult for the Trust, and with such huge numbers of positive cases, and particularly the impact of the variant of concern, the new strain of COVID, this led to a very significant impact on staffing and on our services. The total positive cases as at yesterday to date was over 2,000 now, so 2,187 so far since the pandemic began. Throughout December and January, staffing was very significantly affected, impacting on almost every ward and department, with over 1,000 of our staff actually testing positive in the months of December and January. As the population rates per 100,000 peaked at 1,117 for Hastings and 1,040 for Eastbourne, that's probably not surprising. And as Joe says, many of our staff live locally. The average rate for England at that time peaked at approximately 700 in early January. So as we know, East Sussex was significantly above that England average. The impact of all of that did lead that was especially true for registered nurses, albeit our healthcare assistant numbers were also quite significantly affected at the same time. And as significant additional capacity was required for some time, then that did drive even greater demand. System mutual aid was requested and that was escalated in December, but that additional external support wasn't in place until very recently in the last few weeks, and is very welcome indeed. With this kind of impact on staffing, and especially the scale and the duration, unfortunately, it is likely that there has been an impact on quality. But as we've said, I think it's very important to say that our staff have really gone above and beyond and worked incredibly hard and did the very best they could in extremely difficult circumstances. The last 2 months have seen unprecedented challenges, and as I said earlier on, I'm incredibly proud of and very grateful to all of our staff, and once again want to offer my thanks to them and our armed forces colleagues who are currently supporting us, and indeed colleagues from the CCG and beyond. I'm sure that Steve will talk more in his report about the significant impact on staff and all of the amazing work to support our staff going forward, and the need for them to recover before the Trust begins its restoration of services. Important to say that many staff were redeployed to patient-facing areas, and that included governance, complaints, and many other central support services. The Trust did ensure, though, that as much as possible, oversight on governance and our key quality indicators was maintained. We did have a system of triaging for complaints, patient feedback and incidents, with the support of the central team in terms of monitoring. The weekly patient safety summit, chaired by myself and Dr. Walker, has continued throughout all of the last surge, and there's been great clinical engagement with very good oversight. Almost all of our senior nurses, including our heads of nursing, our associate directors, our deputy directors, and me, have all been working clinically to not only support standards, but to monitor the standards and the quality of care that we've been providing. On a more positive note, in the midst of all of that, the Trust did launch its vaccination programme Christmas week, and is a designated hospital hub. And despite huge challenges, the teams have now vaccinated almost 20,000 people as it stands today. And as the responsible officer so far, I'm hugely grateful to all of the staff who've made that possible, and also to thank some of our non-exec colleagues who've also supported the teams. So a huge team effort, and just a very positive thing in very challenging times, and quite emotional, I think, for anybody who's spent any time in the hub. And thanks to the chairman for his feedback earlier on about his very positive experience. So I'll stop for any questions before I hand over to Dr. Walker.
Thanks very much, Vicky. Questions from that very comprehensive run through? Karen?
So yes, just in terms of the vaccination, there was an article in the Guardian today, and it was saying that on average 85% of nurses nationwide have been vaccinated. And then they split it down and basically indicated that kind of in the hospital sector it was probably over 90%, but it was in the low 70s in community situations or nurses working for agency and things like that. How are we doing as far as our agency, bank, community, the ones that are harder to reach? I don't know whether you actually have numbers, but it would be good to have some assurance that we're getting out to those harder to reach places.
Sure. So important, I think, to remember a few things. So the vaccine is obviously voluntary. So there will be some staff who, for various reasons, don't want to receive the vaccine. There may be some staff who also can't have a particular vaccine or don't want to have a particular vaccine. There will also be staff, as we know, who are not yet able to have it because they've been sick with COVID, and we know that the numbers locally were quite significant, and as I say, 1,000 of our own staff tested positive, so they have to wait for a period of 28 days. There are also then other reasons staff may have received the vaccine elsewhere, and certainly over the last couple of months there's been a huge increase in the number of hubs providing vaccinations, local pharmacies, GP surgeries, the Brighton Centre. So really a huge scaling up of the operation. Our mandate as a hospital hub is to provide vaccinations to health and care staff locally, and that's a very broad remit of staff, including our own. And we are just in the final processes of validating all of that information so that we have absolute clarity about the kind of staff that we have vaccinated, looking at clinically extremely vulnerable, looking at our BAME staff, and ensuring that anybody who wants to have the vaccine is able to do so. I've worked very closely with Steve and Jenna and our tactical group, really to ensure that we are reaching all of our staff and all of the other health and care staff locally. And I'm confident that we have been able to provide the vaccine for all sorts of colleagues, adult social care, colleagues in local care homes, and a very wide range, Miranda. So we hope to have those numbers finally validated probably in the next week. But I'm confident that we have offered it widely and that the uptake has been generally very good, very positive.
Steve, did you want to add something to that point?
Yes, if that's okay, Chair. Thank you. Karen, I think it's worthwhile mentioning that across the system, it's been identified that there are 108,000 health and social care workers in the county that may well need vaccination. And between ourselves and our partners, we have reached out to all of those 108,000 identified health and social care workers to ensure that they all have access, prioritised access to vaccination. So I think, really just to expand on what Vicky said, there's been at a system level, there's been a very big push to ensure that all of our partners are working together. So that's us working not just with our hospital partners, but with local authorities and the likes to ensure that every single one of those has been 108,000 has been offered the opportunity for vaccine.
Thanks, Steve. David, were you looking to add to that point?
Yes, just very briefly, if I may, Chair. So we're doing twice weekly lateral flow tests on all of our staff, and it's quite interesting to see that about 2 or 3 weeks after we started the vaccination programme, the number of our staff testing positive on the lateral flow test started to fall, and then as the numbers of staff vaccinated came through, I think on our peak day was 21 positive tests. And now for the last few days, it's been 0, 1, 2, that sort of level. So clearly, combined with the number who sadly caught it before vaccination was available, we now have a pretty good level of immunity to the current variants that are circulating within the staff community.
Thanks, David. Jackie?
Thank you. Thanks, Vicky. Accepting all the pressures, I remain very concerned about fall rate. And I know we've talked in the committee and previously about changing our attitude to fall to one of presumed falling rather than assessing. Can you tell us any more about progress with that? Because this does seem, we've had 2 dips, but the trend is up. Can you give us some assurance about what measures we can take?
So it's still on my list of priorities, as many other things are. But I think given the last 2 months and the impact that has had, it's fair to say that it's been very difficult really to progress the work that we wanted to do and still want to do. Myself and Joe have had a very brief conversation about, with this current surge starting to recede slowly, then it really gives me and other colleagues a little bit more time and space to refocus on all of the things that we were doing and want to do and need to do. But I think the last 2 months have been very abnormal. So I think rightly our focus was on ensuring that we were providing safe and effective care. So Jackie, I look forward to bringing information back to the Quality Committee, not just about falls, but all of the other things that we know that we want to achieve. So happy to take that through the Quality Committee.
And I did have another question really, which is about infection control. And I know at the Quality and Safety Committee we do see the BAF, but I just wonder if you could say more about staff acquiring infection, whether or not we are happy with the measures we're taking. I know they comply, but should we be doing more given that we've had such an outbreak?
I think there is still a lot of national discussion and debate about PPE in particular for staff in relation to COVID and protecting the workforce, and that debate is still ongoing. There's been some recent articles that have been published, albeit they're not peer reviewed, and myself and David and others have frequent conversations about that. We work very closely regionally with infection control colleagues and also access the national team. So I'm confident that we are doing everything that we need to do, but we are keeping all of that under review. And I think our infection control BAF is a great document and a good way for us to kind of monitor progress and provide assurance. So I don't think there's anything else specifically to add, and I'm planning in part 2 of the board to talk a little bit more about the processes for monitoring staff in particular. So very happy to discuss that.
Thanks, Jackie. Nikki?
Thank you, Chair. Really, my first sort of point is echoing Jackie's, which is that I think it's important to recognise that the variability of performance sort of predates COVID and is ongoing. So, whilst recognising the significant pressures the teams are currently under, I think it's important that as soon as possible we start to challenge whether it's possible to get more assurance from some of those quality measures, recognising on that first page that I think variable performance is what's flagged. And then the second piece is just I couldn't quite get my head around I think this is you, Vicky, on page 14 of the report, which is the staff, where is it? Apologies, effective care nursing workforce, the staff fill rate for Eastbourne. That looks like it's going up. Is that because it's not as a percentage of something else?
Sure. So Eastbourne in particular, we do have the ability to open additional capacity, which we don't have at the Conquest just because of the space. And we have, over the last couple of months, needed to open quite considerable amounts of additional capacity, so that demand was increased further. We didn't manage to fill all of those gaps, as I referred to earlier on. And just in terms of what that fill rate means, the fill rate is a percentage of actual staff on duty compared to the budgeted establishment or the planned establishment. So I think what that's showing us is that we were far busier than usual, far busier than we would have planned. But what that doesn't mean is that we had a surplus of staff, if that's helpful. But Steve has a hand up, so may have a comment on that as well.
I absolutely follow what you're saying, Vicky. So I think my challenge for you would be, is that graph the right graph to be showing us right now? And is it the most helpful graph for us to understand the challenge?
So, sure. So I think that's a very fair question. I've asked myself that, but it is actually a requirement for the board to see this data in this format. And that's actually one of many recommendations post mid-staffs said that the board had sight of fill rates and latterly care hours per patient day. But I take the point, Nikki, it tells some of the story possibly, but not all. So there's probably a conversation for myself and Steve to see what else we can add to that to kind of improve the overall information and the narrative. So I'm happy to do that with Steve.
Steve?
Yeah, I think it's worth recognising as well, Nikki, that of course the report only covers the period of December, and I think what you're seeing in the report is we knew that this wave was on the way. We took a lot of actions to ensure we had staff availability, and I'll come on to some of those in my report. And in essence, what you're seeing is sort of the increased availability prior to the peak of activity, which was predominantly in January. And I think come January, when we look back and see the whole picture with the January data, we'll see something that's slightly different. So in essence, you've got the first half, if you like, and the second half is still to be played out in terms of the formal statistics.
Thanks, Steve. Thanks, Nikki. Shall we move on to mortality, David?
Thank you, Chair. So if we look at the pack, page 92 out of 162, I'm sorry to take you back to COVID, but it's the main topic of conversation, I'm afraid. If you look at the graph bottom right, I can give you the updated figures as of yesterday. We've had 2,187 COVID admissions. And I think if we define the second wave, I mean, you can choose a point where you want to define the second wave. Viruses don't come in waves, they just come. If we say the 1st of November, then 1,800 of that 2,187 have actually come in the second wave. So that's more than 80% of our admissions have been in the second wave. Sadly, we've now had 649 deaths, which is a mortality rate overall for the entire epidemic of 29%, but actually the mortality rate in the second wave is actually slightly less than the overall mortality rate, and I think that partly reflects the fact we've learned a lot more about the virus and our treatment of it has improved. There are things such as dexamethasone. We know we have to keep patients hydrated, whereas in the first wave we were told not to. We know about the issues with increased thrombosis, and we're protecting patients against that. And also there have been treatments such as dexamethasone and remdesivir and these other issues. And there isn't the same rush to put people on ventilators that there were in the first wave, because that was also thought to be the right treatment. And what we know now is that trying to manage people non-invasively with CPAP is a better move if you can. So I think that the mortality has fallen, and I think I have to say that is given the pressure that the organisation has been under over the last 7 or 8 weeks. It is amazing that they have coped so well, and that the mortality has actually been slightly lower in the second half than it was in the first half. To give you an idea of the pressures, COVID admissions peaked at 52 new diagnoses in one day on the 7th of January. And in terms of definite inpatient positives, there's been different figures bandied around, and that's because there are definite positives, and the peak was 414. But on top of that, there are people who quite clearly are COVID, even though the first test has come back negative, because the tests are only 70% reliable as a single test. And so the true numbers, if you add in the treaters positives and some suspected, goes up into the 440s. And that compares with 75 at the peak, which was April the 10th, if I remember rightly. So you can just get an idea of the different impact. If you look at the causes of deaths in December, COVID has completely taken over, and really those deaths were focused in the second half of December, because community numbers started to pick up in Hastings in the first week in December, and that converted into admissions in the second week in December, and then the mortality rate increased from then on. And then Eastbourne sadly got the same new variant wave hitting them really at the beginning of January. What this does to the SHMI and the RAMI is quite complicated, because SHMI and RAMI were not designed to monitor mortality during a pandemic. And so what they have tried to do is to remove COVID mortality from SHMI and from RAMI, which is quite a complicated thing to do. And of course, it depends on how you define your COVID and whether you include what we're calling the treaters positives and the suspected cases, and whether those get removed. And some of those who have died have gone down as COVID on their death certificate, because the medical staff looking after them were convinced that they were COVID cases because of the CT scan, because of the way they behaved, even though the initial tests were negative. Once you've removed COVID from the mortality, the patients that we're left with are obviously very much the sicker patients. As you know, during a pandemic, patients vote with their feet, and unless they are really unwell with other causes, they don't come into hospital. And similarly, we don't have the throughput through the hospital of the normal elective cases, who thankfully almost universally come through unscathed. And so the overall mortality indices inevitably go up for the remaining patients, because they are selecting to be a higher risk, really ill group of patients who just have to come into hospital, even though they know the hospital is under intense pressure with COVID. And you can get a flavour of that if you look at the RAMI graph, and mortality has been coming down over the years, and you can see that at the start of the RAMI graph, the red line, which is the national line, was steadily coming down until the start of the pandemic, and then it has started to rise, and that reflects the increased morbidity and mortality of the patients. And similarly, our curve has risen with that. And I think, unfortunately, because of our own demography down here, we are impacted more both by COVID and by the patients who have to come in because they have no choice, because we have such a frail elderly population locally, and that there aren't really any other alternatives for them but to come in, whereas some younger people unwell might be able to stay at home. Because of our extreme elderly population, they do end up in hospital. So I think our non-COVID mortality has gone up, and I think there are reasons for that. And I think we'll have to see, once COVID has decreased to a manageable level and the population has largely been vaccinated, we'll have to see how we rebalance SHMI and RAMI and how we come out of it. All I can say is that for the moment we still have mortalities both by SHMI and RAMI which are lower than the national averages, which I think is reassuring. But I think we're going to go into a period of extreme instability of those indices, because the number of patients going through them are so much less, because COVID is the majority of the inpatients that we've had. And I think when we compare ourselves with areas who have not been hit quite so hard with this second wave, who were further away from the origin of the new variant, they may have been impacted less. And so I would predict that RAMI and SHIMI will go back up for a period of time, and I think we need to expect that. I'll talk more about it in future boards as perhaps those figures play through. But I think there's an inevitability because of the way we've been hit hard with COVID and the impact that will have on the remainder of our patients. I'll stop there. Sorry, it's slightly complicated, more complicated discussion than normal.
Yeah, but an important and helpful one, David. Thank you. Jackie.
Thank you. Firstly, I'd like to acknowledge the strides we've made in improving, particularly RAMI and SHIMI over the last few years. So yeah, we've started from a point of improvement anyway. I'm just thinking, as we're hearing this, what changes are we starting to think about, how people come in, our surveillance measures for COVID going forward, so that we can track it better and protect inpatients better? Are we starting to think about, you know, like we used to do with MRSA, everyone had to have, well, they still do, had to have swabs before they come in. Will there be some kind of onward surveillance that we will?
Oh, yeah. So absolutely, Jackie. The problem we have is that none of the tests for COVID are perfect. They are highly dependent on the quality of the swab and how deep you go within the nasal cavity, to not to get too technical. So that is an issue. But secondly, all of the tests are affected by community prevalence. And when community prevalence is high, as it has been recently, the tests become quite accurate, because a positive really is a positive, and a negative on the whole really is a negative. And certainly that's the case for our main testing machine, which is a PCR machine called Perkins-Elmer, which is the main one that we are using. The Menarini, which is the sort of supposedly a bedside, although we're actually doing it in the labs, is the rapid turnaround test, looking at people when they come in. Is more sensitive to prevalence. And so as the community prevalence is falling, and the community prevalence is now, I looked yesterday, is now less than 200 for all of our areas. And I think Joe said earlier it peaked at 1,200 in Hastings. So we're down to roughly a sixth of the prevalence. Inevitably, that's going to have a knock-on effect, and there will be both false positives and false negatives, but more false negatives. And that does give you an issue, because false negatives are the most dangerous thing, because if you have a patient who's a false negative, you can then place them with other people who are true negatives, and then there is a risk of cross-infection, and we'll talk more about that later. But there is no way of getting around that. That is a function of all tests for any disease, but is a particular function of testing for COVID, where even the best tests only have 70 or 80% success rate.
So I can see a future where we presume everybody is positive until proven negative. But having recently had a family member do a 2-hour trip for a 2-minute test, it's going to be very difficult to get compliance for our elective patients.
I think the elective patients aren't a problem. We will be testing for some time to come. We will be swabbing elective patients, and they'll be having a period of isolation before they come in. So they are not the main worry. The main worry are people who come in and seemingly have non-COVID symptoms, test negative, go into a non-COVID area, but actually are brewing COVID, and that's the problem. Now, the incidence of that will go down as the community prevalence goes down, but our ability to pick them up with testing also goes down, just because of that's the statistical way these tests work.
Yeah, okay, thank you.
Vicky, did you want to add something on that point?
Just to say that I think this is the kind of beginning of the journey, I guess, of how we learn to live with COVID for however long, and discussions already underway. But you know, myself and David and Tara and others saying, so what does that mean for the next year or 3 years, or you know, the World Health Organization would say 5 years actually in this country. So, and it will change as time goes on. And it will probably become endemic at some point, as viruses do. But I think it's in the next, you know, 2-3 years. What does that mean for us when we're trying to provide services in a different way? So I think it'll be an ongoing conversation.
Because we're only 6 months away from winter.
We are.
Jackie, that's not really my line.
I think that I don't know if you were listening to Jonathan Van Tam yesterday. He often speaks the most sense. I think the likelihood is that this will become like flu, and they will have to tweak the vaccines on an annual basis, and so we will probably get there will be a September COVID and flu vaccination program every year where we get the latest variants covered. And I think that will be for some time to come, I'm afraid.
Yeah, I think that's right. Amanda.
Sorry, so just to say, from our elective work, if we are working within a modified infection control, and we are going to be a long time before we hit the productivity levels that we have enjoyed before. So that's sort of my final point.
Yeah, to some extent, but I think that once we come out of this peak and it comes down to manageable levels, we will have to have plans in place for the elective programme where we are swabbing and isolating people before they come in and making sure that they are cohorted together. And I think that we had made great strides towards that during the summer, and we'd got the productivity levels back up. So I think that once the prevalence goes down, we will be able to do that again, Jackie. So that I don't see that as the main issue going forwards.
Thanks, David. Amanda.
Thank you, David. You are able to present such a complex presentation in such a really manageable way, so thank you for that. And I do agree with you about Jonathan Van Tam. He is an excellent speaker and I learn a lot from him. I'm just about to show my ignorance, and so do forgive me, but I am really perplexed by the last bullet point on your slide, which says consultant acknowledgement rates of the medical examiner reviews was 82% in October. I'm not sure I understand that statement and what it really means. So I'm really sorry, David.
So that's okay. There's been a change of system over the last few months, which I've spoken about at board before, probably before you became a non-executive, Amanda, but there's a new system of medical examiners introduced in the UK over the last couple of years. It was piloted in certain hospitals, and then it was supposed to become a legal requirement from April, but in fact, because of COVID, they've delayed it. But eventually, we implemented it last April. So I have a team of 9 medical examiners with a lead one, and then 4 on each site, who now analyse all the deaths that take place and go through them and see if there are any issues that require further assessment. If there are issues that require further assessment, then they flag them, and then they go through to the individual team to put them through the M&M process. And so what that's referring to is that there were 82% of those people were taken over by the consultants for that M&M process, compared with 73% in September. I'm afraid that will go down again because, sadly, a lot of the mortality has taken place in the people who've been busiest in this period and have had the least time to do it. So the next set of figures certainly for December and January will be poorer than that. But that's what it's indicating.
Thanks, David. Thanks, Amanda. Shall we move on from mortality? Thank you, David, to access and responsiveness. Tara?
Yes, thank you, Chair. I wanted to start with some good news. So since we last met on the 1st of December, we've had our cancer targets, National Cancer Standards, published for November period. And I'm pleased to say that as a trust, we actually met the 2-week wait standard, the 31-day standard and the 62-day standard, which I think is the first time we've done that since 2014. So we must celebrate that, because as a trust, it's something that we shouldn't lose to COVID. And actually, we were 8th out of 121 trusts. So I think that is just shows what we can do. So I didn't want to miss the opportunity to do that. And thank actually all of the teams, because everybody has worked really hard to change the culture and the way that we think around cancer to improve that situation. So that's some good news to start with. Obviously, as we come out of that reporting period, we have now gone into the pandemic, and we have seen a change in the way that we are managing all of our waiting lists. And again, we did achieve second out of our 111 trusts for RTT as well. So November was a really good month for us. And I think what we can say is it took us into this pandemic in a much better position, with a much better understanding of our waiting lists and how we can work together as a system to ensure that we deliver the national standards and obviously the patient experience. For those that we know that we've now following the national guidance, and we clinically prioritise our waiting lists, and that's P1, so priority 1 to priority 6. Priority 1 are patients that need their operation within 72 hours. P2 are those patients that need an operation within 4 weeks. P3 is within 12 weeks. And P4 are those that are over 3 months. Now that is all clinically validated. P5 and P6 relate to patient-initiated delays as a response to COVID or non-COVID. So we are working to that criteria. In December, it was agreed nationally that we would then operate on patients that are classified as P1 and P2, those that are clinically urgent and cancers, and also any patients that are clinically reprioritised as we review them and go through. We continue to do that, but obviously we will see that there is a dip in the performance against the national standards over the coming months. Although I can say that as an organisation, we are already looking how we deliver our services, and some we will see how we have changed the point of delivery, and I'll give ophthalmology as an example. We have moved our operating off-site so that we can continue to deliver the services and still deliver a lot of patients outpatient appointments virtually. So there's a lot going on, and again, to reiterate, not only are staff being redeployed, but they are moving the way that they are delivering services, and they're doing that in, you know, turnaround times that you would never ever expect to see. So again, that is something that we need to praise our staff for. As a trust, we continue to ensure that our patients understand the expectations of them and of us with regards to discharge. And we are ensuring any patients that are coming in through the pre-assessment pathway, they have an understanding of what is expected, and also they get an overview of how long they will be in hospital for. And we are using the PHE and national guidance with regards to procedures and the information that we're giving to our patients. Patients that are coming in as an emergency, we are trying to ensure that we give them the right data information at admission with regards to their stay and for discharge. And that is a project that we are currently really focusing on with the system to look at how we can manage our patients for discharge and move patients through the pathway. So we continue to work on our material and with Health Watch to see how we can ensure that patients understand what's expected. And we have acknowledged that actually some of our terminology needs to change. On the website, we talk about getting you home, but we don't actually mention the word discharge. So if you're trying to do a Google search through the internet about what you're expected as a relative or as a future patient, we haven't made that easy. So we're just changing that now and starting to work that through. Our front door performance, we can see from the report that we haven't been achieving the national standard. And this is something that we've acknowledged with regards to the COVID response. However, again, good news, over the last 2 weeks, we have seen a significant change in our performance. We have on a couple of occasions actually met the national target, and it's something that the teams are very, very conscious of. And again, praise to our staff that actually they're really still making sure that they're mindful of the patient experience and making sure that we do deliver those targets. So ITU capacity has been something that has also been a sort of pinch point for us. We've redeployed our staff, as we know that we've already talked about, but also it has had some impact on the way that we can deliver some of our services. Particular urological procedures have been, for cancer, have been a problem with regards to the ability to deliver post-operative ITU capacity. What we've done is worked as part of the system. We have sent our patients to panel, and we have looked at working with our colleagues. We have sent a couple of patients to Guildford because they have been able to offer post-operative ITU. Our breast patients are going to QVH at East Grinstead, as are our Max Fax patients, so they are going to green sites. We are working with the independent sector here and looking at Spire and how we can put patients through, but we continue to provide that level of patient care on both our sites through our super green beds. So we still are working and making sure that we can deliver the waiting lists and the patient procedures that we need to. Our demand for red, amber or green beds, so that's our COVID positive or our COVID suspected or COVID recovered beds, that is something that is constantly changing. We are constantly responding to the way that our patients are recovering and the type of patients coming through a door. So we really are making sure that we can respond to the need. And again, as a recognition for us as an organisation, we have been praised through the silver meetings with regards to the fact that we have managed the whole COVID response and the delivery of services between our two sites and haven't, using the terminology, tipped the system over as we have seen happen in Kent. So again, it's a real testament to everybody that has put effort into the delivery of all of the standards that we have here. Also, during the early part of December, we implemented Nerve Centre on the 8th and 9th of December at the front door, and we are still working through some of the data. So some of the data that you can see in this pack with regards to our front door performance and urgent treatment centre, some of that data still needs cleansing. So you will see an improvement in the next month's report as we're working through that. We have seen some, as we've been referred to earlier, patients voting with their feet. So patients are not presenting in the early stages of disease, but are coming in a lot later, so are more acute. And again, that has an impact on the time in ED and the way that we move patients through. We are seeing the patients coming through 111 first, and also we're trying to do the admissions avoidance. We've been working closely with the Ambulance Trust, and again, we are seeing and have been praised for the way that we have turned around the ambulance waiting time so that that is a much better patient experience, but also allows for the ambulances to achieve their targets as well. So I think there's a lot that's happening at the moment, and to pick up on a couple of the other things that Joe said that I'd pick up on. So Furwood, we have opened Furwood in response for the need for red beds. So those are patients that are still COVID positive or have achieved the 7 days, and then we're going out with still a positive test. So we have staffed that. It has been very difficult, and I think, Vicky, that's one of the areas that we had as an additional stress for Eastbourne, and we are looking to close that down over this week as we can start to move those the capacity back into site. But we've also working with our partners at Rye and have increased the Rye beds by 4 and looking what we can do to deliver more community-based care. With regards to restart, as I said, we're starting to look at some of the things that we've off-sited. For example, again, ophthalmology. We're now looking at whether we can restart that Jubilee service on site, and doing that in a very controlled fashion, understanding all of the implications of restarting those services. It's not just the restart of the service. We need to understand if it's safe for patients to come on site, but also for if we have redeployed staff from those particular areas, what's the knock-on effect? So we're trying to do that in a really controlled fashion, and that will allow us to start a restart process and look at each individual team. So it might be that as we look at a team, we can say to them, we're thinking of doing this in the next how many days or weeks, so we would like some of you to be able to take some leave. So it really is about having that balance around everything that's going on at the moment. There's a lot of work going on around discharge, as you can appreciate, because it's not all about opening additional beds. It is about making sure that there is the best patient experience and discharging patients in a timely fashion. So we are working, we have had not only daily incident management meetings, we have daily operational meetings with our system partners. And we're looking at how we can identify those patients that are medically ready for discharge and make sure that they are discharged in a timely fashion. So again, working as a whole system, we have a member of our team who is pulling together the numerous action plans that have been put in place across not just the acute trust, but for the local authority, and then we're working those through together. So there's a lot of work going on at the moment. I'll pause there just to take any questions, because I appreciate there's a lot of information.
Tara, thanks very much. That's very comprehensive. Just before I open it up, I feel as though I ought to go back to the November performance, particularly, but not just around cancer. Colleagues who were sitting around this table when I joined 2 years and a week ago will remember that this was the subject of a spirited and enthusiastic exchange, let's call it that, between us about the need to particularly do well on the 62-day target in the same way that we were with the other cancer target. So so thank you and well done. I wanted to say about that. So having been grumpy about it 2 years ago, I feel as though I ought to at least celebrate and be appreciative of it now. And also the RTT planned care targets. Now I know that that's going to look different next time we look at the figures, but that's a very significant achievement. So so let me say thank you for that as well. Now let me throw it open. Jackie first.
Thanks, well done, Tara. That was really good. Just a couple of things. The length of stay, non-elective length of stay, is up slightly, but spells are down slightly. So is this an issue of getting people home because they're more frail, or is it because there are restrictions into care homes? What's the key driver? I know some of the London boroughs have been very strict on, you know, one case means 28 days before anyone else can be admitted into a care home. So is there anything like that affecting us, or is it because people are just more sick?
I'm going to say all of the above, Jackie, really, because it is that mixed bag. We have got some patients that, as I said, they're coming in already very sick, so the acuity is high. We have been working, as I say, closely with our local authority and community partners with regards to taking patients back, and we have been making sure that Bexhill Irving unit has really been the sort of conduit flow through for those patients. So it is all of the above, and it really depends on, I suppose, where we are in the pandemic response as to which was the bigger issue.
Okay, and my other question was just, you haven't touched on it yet, I don't know if you're coming on to it, is the waiting list for 52 weeks and how, you know, how that's going to impact our performance going forward.
So as you can imagine, I'm a little bit sort of anal about this. So we just look at, I've got my little spreadsheet in front of me. So when we were in October last year, coming out of the first wave, if you like, we were at 258. Today we're at 267. So actually we brought that right the way down into, you know, we were down into sort of the 80s. And I think it shows that we can do it. We have absolute oversight of our waiting lists, and we do know that we can deliver this, and we're starting to look, as we come into the restart, that any patients that are our long waiters are the ones that we're looking to deliver alongside the P1s and the P2s. So although it's a high number, a lot of that is patient choice. And there has been a fear through both waves of people coming in because of the fear of COVID, but we will manage that and we will get that back through, and we do undertake the appropriate harm reviews for those patients.
Okay, thank you.
Thanks, Jackie. Jo?
So I suppose just 2 points really. One is I just want to say thank you to Tara. She's come in as a new Chief Operating Officer right at the beginning of a second wave. And Tara's led the team really well. And we talk about our frontline staff, but actually it's the wider team that sit behind this that help things to deliver. So I just wanted to acknowledge that. And she's done the one thing I couldn't do, which was to get 62 days. I'll take everything else, but I'll give her the credit for that one. So and even now it's yes. Anyway, it's marvelous. That's important point. Yeah. I think just when we talk about well, when we get to the point of talking about recovery in weeks to come, I think just sort of a bit of a heads up. It's great to know that we were 8th in the. I mean, it really is great to know we're 8th in the country for 62 days. It's great to know we were 2nd in the country for RTT. I think what we've got to remember when we're looking at recovery, this is about equity of access to patients over wider geographies, and we will have a role in supporting patients beyond East Sussex. So whilst our East Sussex residents are absolutely vitally important, it's not right that we have some patients waiting in one area of Sussex who might be waiting 30 weeks or 50 weeks or even 60 weeks, and we've got others that may be waiting significantly longer. So we will have a role as a system partner to ensure that we've got equity of access to our patients, at least on the 52-week basis. And Tara's already also talking about one of our specialties and whether we can support with some access to cancer patients as well. So we wouldn't want to see any detrimental impact to our East Sussex patients, but just before we kind of charge for being the best in the country at, you know, RTT and cancer, it's really important that we play our role in the system as well. So I just wanted to flag that because that might become evident at a bit later time. So.
Thanks, Jo. Yeah, a conversation for a different time on that supposed principle, I think. Any other questions for Tara? Great report, Tara. Thank you very much. Now, we're running a fair bit behind time. And we're due to take a break at this point. Steve and Damien, if you don't mind, I'm going to suggest that we take the opportunity for a 15-minute break now and come back and come to things afresh. So I make it 25 to, so shall we return at 10 to? Yep. Okay. Thanks, everybody. See you in a moment. If we can restart, Steve, with leadership and culture report.
That's great. Thank you very much, Chair. I'm very conscious that the report in the packs covers December and things have changed quite a bit since then, as we've already talked about. The report also only covers a small part of the story. So what I'm going to try and do is focus this the verbal update on the broader aspects, some of which we've talked or touched on already. As we've already said, December was a challenging month for the Trust. It was characterised by increasing demands on staff across the Trust, alongside increasing levels of sickness, which at the end of December culminated in levels similar to Wave 1, but which have gone up since then. And to give you a flavour of that, total sickness in Wave 1 for all reasons maxed out at about 478. In Wave 2 at about 520 people off at any one time. To give you a flavour of COVID, in wave one. We had about 126 staff off with COVID. In wave two, it was just under 250 at any one time. And on top of that, there were about another nearly 300 staff that were self-isolating at a time. So you can see the sort of scales of the challenge that we were facing. I'd really like to pay tribute to all of our amazing colleagues across the Trust who have selflessly risen to the challenges that they face. We've seen people, including our own staff, non-execs, volunteers, charities, bank staff coming forward to help us through what's been an incredibly challenging time. And I want to put some context on a couple of things that have already been said, some context around the vaccination centres and around Furwood. The vaccination hub at Conquest was opened with 1 week's notice, and alongside its partner hub at Eastbourne, at full capacity, can deal with literally thousands of patients each week. In simple terms, through the dedication and hard work of our staff, we planned, staffed and opened our biggest outpatient unit in 1 week. And you can only achieve that through some really incredible work. Furwood is another example. Furwood was an additional requirement for us, an additional 18 beds that we managed to staff over this period. So this is additional capacity. It's on top of what we were normally being asked to do, and at the time, at a time where I've already said, you know, the sickness levels and the pressure on people was incredible. We've already said on a few occasions as well about the importance of supporting our staff during this period where they have been under this pressure. And I want to spend, I suppose, a couple of minutes talking about that now. Our aim has been to support both the psychological and the physical welfare of the staff, to make things as easy as we can for them and to support them as much as we can at these difficult times. Things that we've done which have helped is we're providing hot meals on the wards. So when people, when people get a break, they're not spending their time doffing and actually getting no time to actually have a break. So hot meals on all of the wards and for staff across the organisation. We've provided snack boxes for staff across all parts of the organisation. So again, just making things easier for them. We've opened wobble rooms on both sites where people, these are in the chapels, is where people can go if they just need a break, they just need to talk to someone, but the support is there. The chaplaincy have been fantastic in supporting people. We've been providing specific support for absent staff, making sure they're okay, making sure they're feeling supported and helping them to return to work. We've put psychological support in place for teams and individuals. We've introduced trauma therapy processes to support teams and individuals. And not only are we doing that now, we're putting in place longer term support through this, through introducing TRIM. We've got the time to talk service, which means anyone 24/7 can actually just pick up the phone and talk to someone. We've got the Care First counselling programme, which we're running 24/7. Sussex Health and Care Service partnership have actually launched a full psychology service which staff have access to. We've obviously been supporting people through vaccinations and lateral flow tests, and we've been doing a lot to support teams who have sadly experienced loss in their teams and have gone through trauma. And we're continuing to look at ways in which we can continue to support people, both now and as we come out of the current pressures. And I've mentioned this already, but I think we all know that sometimes when you get the opportunity to stop and take a breath, that's when the enormity of things can really hit you. So we're very, very conscious of the need to ensure that we put even more support in place for staff going forward. I think it's worth noting something that was said very quickly at the beginning of the meeting, which was the appointment of Miranda as our wellbeing guardian to ensure that health and wellbeing of our staff remains at the centre of our thinking and activity at the board. And never will this be more important, I think, than over the next few months. I think clearly at times like this, it's really important that we prioritise the activities that are going to make a big difference. And along with other trusts across the rest of the country and in line with national guidance, we have deprioritised some things like the updating of mandatory training and appraisals. Over the coming months, we're going to put plans in place to recover our performance against these. We'll set trajectories for them, though it should be noted actually that the dips in compliance aren't significant and they're going to be easily managed with a sensible plan. To support the prioritisation of activity, we've also redeployed staff, as Tara's mentioned. Over 250 staff are actually working in different roles across the organisation at the moment. We've placed a real focus on the recruitment of volunteers, on new bank staff, and on bringing in permanent staff as quickly as possible. During December, we contacted all staff who were due to join us in January and February, and we were able to change our plans for January to triple the number of induction programs that we ran for faster onboarding. And in fact, we increased the number of clinical staff coming through our induction programs and joining us in January as a result of our plans from December by over 200%. In December, we filled over 12,800 shifts through temporary workforce, and we built our temporary workforce numbers and capabilities even further, not just looking at typical workforce, but workforce that would be important to us at this time. So, for example, we now have 10 psychologists on our temporary workforce, which is up from, I think, 4 earlier in the year. And we've got over 100 vaccinators on the bank, as well as vaccinators from our own staff. We've also put in place a significant program to shorten the time to recruit. And I think there's a lot we can learn from that as we go forward in terms of how we can simplify our processes, make them work more effectively and more efficiently. We've also not forgotten some of our normal activities, and one example is around our data quality. Data quality in HR and in ESR, our system, has been a challenge for the Trust, and 2 years ago, against 423 trusts, we were 302nd in the league table. This month, we're 26th in the league table, our best showing ever, and in fact we're second in the region for the quality of our data. So we haven't forgotten some of the key things, that help us to manage things better as well. So it's been a difficult month, it's been a challenging month, but it's been one in which colleagues across the Trust have risen to the challenges they faced in the most amazing way. And as I said at the beginning, and I'll say again now, we've talked about some of the amazing things we've achieved in the last couple of months. That really ultimately comes down to the commitment of every single person working in the Trust, both in leadership and frontline. And I'm incredibly proud to have joined a Trust where we can rise to this challenge in this way. So that concludes my update, Chair. Obviously, I don't have any questions.
Thanks very much, Steve. And on the new staff arriving, I joined. We've got a number of overseas staff who joined at the beginning of the month, about 24 of them, and I joined them at the beginning of their virtual social evening on Thursday when they had a quiz night, and a really enthusiastic and keen bunch they were too. It was great to meet them, and I went out of my way to thank them for joining the Trust at what is a difficult time, and a difficult time for the Trust, and a difficult time to try and settle into a new country and a new job and everything else. So it was great to see the effort that's going into to help new staff from overseas settle in, but they were a lively bunch. It was nice to spend a little time with them. That was great.
That's great. Thank you, Steve.
Miranda.
Thanks, Chair, and thanks, Steve, for all that you and the team have done, because I know you've done a phenomenal amount of work on this, and also you've only been here 2 months, I think, and even though it must feel like you've been here for a very long time. I wanted to ask you about something that you and I have touched on actually in conversations before, but something that I was reminded of reading an article by the President of the Royal College of General Practice or Physicians today. In a recent survey, although a fifth of respondents said they would their commitment to the NHS, and this was junior doctors, their commitment to working for the NHS, a fifth of them said it had been strengthened by recent experience. A third said that they would be thinking of leaving and finding another job, and I think there are feelings like that amongst staff groups as well. And I wondered what your thoughts were about that and what we can do about it. Are we already doing something about that and about morale?
Yeah. So I think a couple of things in response. I mentioned earlier on, I mentioned in my update, Miranda, about our awareness that this is a particularly challenging time that we're entering into, many people would have been under significant pressure, and they will be thinking about their futures. And we are actively planning to think about how we can support people both psychologically, physically, mentally through this phase, how we can probably maximize our engagement with people, and how we can keep people on board. I think this is something which is work in progress at the moment. Much of it is building on what we've already put in place in order to support people through this time. But I also mentioned earlier in one of the other sections about, I think it was when we were talking in the bath, about the risk going forward, which needs to very much be on the trust register around this one. So I think my answer for the moment would be, we very much recognise it is an issue. We're working hard to engage with all groups across the trust, but now more than ever is the time where we really need to put more and more focus on it, and it's something I'm very interested in exploring and discussing with you in pod over the next couple of months.
Thanks, Steve. Vicky.
Just to say, Miranda, I think what has struck me over the last couple of months is that even at its most difficult, and it has really been very difficult, I haven't personally had any staff say that they want, to leave ESHT. I think people have had probably the most difficult time of their career, and I don't think we're unique in having staff who maybe are thinking, if this was to happen again, could I do it? Would I want to do it? And looking forward to next winter. So I think what gives me some positives out of that is that our staff feel as supported as they could possibly be. But if they decide, and I suspect there will be some staff who are probably at that point in their career where, they could stay for another couple of years, but I suspect they will, maybe reconsider that. But I can honestly say I've not had any feedback that kind of reconsidering, is anything to do with us as an organisation or as an employer. But I think just the toll that it's taken on everybody, and not just our staff. So, I think it's important that we're clear about how our staff feel we have supported them and we have dealt with this. But I certainly thus far have just really had positive feedback. Although it's been exhausting for everybody physically and emotionally. But I think that as an organisation, we've done the best that we possibly could to support staff.
Thanks, Vicky. Joe and David, did you want to follow up on that point? Joe first. No, different point.
Mine's a different point.
David, were you on that point?
Coming up from me. Yeah. So, I mean, taking up the junior doctor and the doctor theme in general, I think that as ESHT we have done a really good job of supporting our staff, and I think Steve's done a really fantastic job since he arrived in doing that. It's been a very difficult period, but I think that the wider point is correct, that the junior doctors are still not recovered from the disastrous reorganisation of the contract with Jeremy Hunt, and just think of all those junior doctors who went to Australia because they were fed up with the NHS and Jeremy Hunt at the time are all now thinking, thank goodness I did that because there's no COVID here and I'm having a great time. Are they really going to want to come back to the UK after all this has happened? The answer is no. Also, I do know a lot of older physicians approaching 60 or just beyond 60 who were intending to work on to 65 who've actually said, I just don't fancy being in PPE and doing this for the time to come. So I think it is going to force quite a lot of the older physicians who we would have got several more years of good work from to retire early. So I think there is going to be a significant medical staffing issue, and I'm sure that Vicky would echo that in terms of nurses and the strain they've been under. So although we are doing a lot and will continue to do a lot, I think it is going to lead to a staffing crisis over the next couple of years, and we have to think about how we manage that. And we were already doing some of that work in terms of things like physicians assistants and physicians associates and doctors assistants, and we'll have to carry on with that. But watch this space. I think it's going to be a difficult time in the NHS for the next few years.
Yeah, I agree. Just coming into their prime, of course, as they get to 60. Jackie?
Thank you. Just a couple of points. Just on the wobble room, I bumped into somebody who'd actually used it, and I completely misunderstood the concept of wobble. I was thinking more of balance, but once she explained it, I kind of got on board. But they're very positive about the informality and the openness of it. So thank you for that. The retention of staff, I think, is an issue in terms of my concern I raised earlier, just about what does the new normal look like? How are we organised? What do we do? You know, the toll on older staff of some of our current shift patterns or ways of working, we might just need to rethink some of that. I haven't met anyone who's enjoyed working a 12-hour shift in this pandemic. And I wondered if there was more the board could do. We're not doing quality walks, but whether or not we could align temporarily to somewhere just to show that visible support. I wonder if we could do more than we're doing. A positive from the redeployed staff that I've spoken to, most have enjoyed the experience of working outside their normal role and meeting other people, and it has either confirmed they're happy in their current role or they actually embracing the opportunity to move. So I think thanks to all those staff who did redeploy, and I think it's been a generally positive experience to connect them with the rest of the trust. And my last point was, are we at some point going to do an analysis of sick time when people have come back from COVID? Because I understand some people have come back a bit soon and then gone off with something else. So, you know, we're used to seeing stress or back pain or whatever, whether or not we look at sick patterns going forward to see where some of the stresses are on health. So that's my 5 points. Sorry, it's a bit rushed.
I mean, in terms of the last one, I think it's important, and yes, we are looking at sick patterns. We're already doing it. One of the things that's interesting, and we need to figure out what it tells us, but if you just did a quick bit of maths on the numbers I gave earlier, what you'd actually see is the number of people that were off with things other than COVID-related illnesses is down over the period. Now, we don't know if that is because people are just really, really committed and they're just thinking very seriously. We don't know if it's that people who have got, I don't know, MSK to take example, are coming in and saying, I just need to help out and come in. And we need to be very, very, very aware of what's driving people to come to work, as well as what's driving people to be away from work. And I think that's going to be a big part of what we need to look at going forward. I think in terms of work patterns, what people want, I guess what I would say, Jackie, is that, you know, if you look at the crisis that we talked about before may come our way, everything needs to be on the table in terms of how we work, you know, how people work, when they work, where they work, how we support them, and how we think flexibly about what our needs are. So I think that's a point very well made. And I think, and I actually hope that over the next couple of years, what we'll see is a real change in thinking about, about how we engage with people, how we work alongside people, and how we, how we deliver those services. And I'm sure that will be allied. I hate the term about getting back to normal. I think this is about going forward to a new normal. And there's so much learning from the last few months. Some of it I think is very, very positive, and I'd really like to look at how we can take that learning about the way we work, when we work, how we work, and indeed our processes, to think about what, how we can just do things better as a result of that going forward. But that isn't going to happen by accident, so we really need to focus on it.
I would, just before we move, I would add, so I agree with all of that, Steve, and I would add one thing to that, which is, the old maxim about people don't leave organizations, they leave people. Also, as we reach a new level and a new way of doing things, that comes back to the fore again. So it's not just about policies and processes and procedures that get put in at a sort of top level. It's the leadership behaviours of middle managers, senior managers, and supervisors that can make the difference between whether or not people want to stay for that extra year that David was talking about, or an extra couple of years, or whether they choose to go on to something else. So there is something about understanding what are the right things to do, and then underneath that is making sure that we have the behaviours through the organisation that underpin and support that. And I'm guessing that was implicit in what you were saying, I think, Steve.
It was, yeah.
Amanda.
Most of mine has been covered by Steve and Jackie, because I was very interested in terms of the long term, but I'll leave that aside. So I've only got one little question left, and it's a strange one, but given that the vaccination hub is such a positive thing, it's an experience that everybody enjoys, whether you're being vaccinated like our chair, who enjoyed every second of it, or you're giving the vaccination. It's a really, really positive experience. What I may have picked up, and it could be wrong, is that at first opportunity, people are filling the shifts in the vaccination hubs, and actually there's a greater cry and a greater need for ward-based care, and we're using different incentives to maximise that. Is there a way of rebalancing this so that we get the right balance of, you've done a couple of shifts on the wards and they've been hell, do a shift in the vaccination hub, something a little bit more intuitive or prioritised rather than first come, first serve. And forgive me, I know it's a very, very tiny little minutiae, but it was just a way of thinking about the well-being of staff and the positive impact that it has.
Yeah, it's an interesting one, Amanda, and actually one which some of our staff working in some of our very tight and stretched services have sort of figured for themselves as well, and maybe we can help them with. So we do have some staff that they're doing their full work, and then they might actually do a bank shift in one of the vaccination hubs, almost as a bit of a release and a bit of a reminder from things. And it's a difficult one, isn't it? Because we're very, very stretched in terms of our care services, and the services to our COVID patients as well. And it's a very difficult balance to get. But I think there is some learning going forward in terms of sort of variety of thinking as well. And I said just now, nothing should be off the table.
Exactly.
As we look at this going forward, and I think it's a point well made.
It's not for now, it's for forward thinking, and also to really, really emphasize the point of the middle management and the support that we are giving the middle management, because they are in some really difficult situations and middle management often get squeezed and forgotten. So it was great to hear us focus on them as well.
Vicky, did you want to add to that particular point?
Thanks, Chair. Just you're right, Amanda, and actually there was some concern, understandably, at one point where we had staff from ITU, staff from all sorts of areas who were offering availability for the vaccination hub, and we didn't anticipate, I think, initially that it would be so important for staff in terms of their mental health and respite, and to get away from a COVID zone with full PPE, and to have something that is far more positive, and they're part of something really quite historical. So although I had some people saying, understandably, gosh, can they not do their extra here? I said, well, they're using themselves to do it, and actually it's very important because it is a form of respite. But I think you're right. I think what it shows us is, and also with all of the redeployments, we've had since last year some staff who've changed entirely specialities and have just been amazing, and then said, actually, do you know what? I'm not going back to where I was. Actually, I'm going to stay now. So I've had this huge change, which was terrifying, but actually it's pointed me in a direction that I didn't even know I wanted to go. So I think if this pandemic is teaching us anything, as Steve says, it's about how we work, where we work, and the opportunities that we have. We've had you know, SCABU nurses supporting adult inpatient areas. We've had midwives supporting surgery, and I think what that shows is that most people can do most things, and the kind of teamwork and the collaboration that we've seen is extraordinary. So I think it's a great opportunity, and there's some real positives there about how we have a far more flexible and versatile workforce going forward. So there's some great opportunities for us, I think.
Thanks, Vicky. Joe?
I'll be brief, but I just wanted to, on a very well, not very, but very related topic. So I did just want to acknowledge Steve, who has only just come into the trust, and say thank you to Steve, because he's really come in, you know, literally feet hitting the ground, and sort of, I think even before it started, was allocated to work with Vicky on the vaccine programme, but, you know, done tremendously well. So thank you to Steve. I think we also just want to draw out his team as well. So, you know, we don't recruit people without, you know, a workforce recruitment team. We're looking after the well-being of, you know, actually, if you include all of our staff, nearly 9,000, if you include our agency and our bank staff as well. And so a really big shout out to the wellbeing team, and also occupational health, who are going way beyond the remit of a normal occupational health team. So just, I don't want to miss anybody out, but I think just to recognise that, and I'm just going to pause because I'm just looking to see where it fit on the agenda and it doesn't. So I'm going to say, but also just want to recognise the whole exec team. We talk about people doing sort of over and above. David's been working a full shift, either clinically or as a medical director, and then going in and vaccinating in the evening. Vicky's been working tirelessly to make sure that we've got the safety on the wards, as well as the vaccine programme. Tara, we've talked about. Damon's keeping us on track with the money. It's there and it's a reality, and without that support, Richard's been still managing to keep focusing on our strategic work, because we can't just stop everything, and Alette's been supporting as well around the governance and a whole range of things. I'm going to miss people because I've picked them up probably, but I do just want to recognise that for the whole executive team. I know Chris isn't here today, but yes, massive thank you from me, and I think from the rest of the organisation as well, because without their leadership, we wouldn't be able to deliver what we are. So I thought I'd say it now under the people section.
Yeah, thanks, Joe, and I know from conversations with non-exec colleagues, I think we all feel exactly the same. So so a big thank you to everyone. So let's move on at that high point and talk about finance, Damien.
Does that mean I need to maintain the high point? Could be an interesting challenge. So
good luck with that.
Yeah. So briefly, I want to go through how we're managing the block contract, how we're trying to get to year end, and what are the first signs of what the contract is going to be next year. So in terms of the block contract, we've moved from a challenge as we're making COVID claims to basically being given a block contract, and then the reviews being very retrospective. So we're getting questions about previous months now. They're still occasionally stopping payments, but for the most part, we're managing to maintain what we're spending locally and getting that approved. In terms of the block contract, we'd originally planned for an increase in elective activity. What we've done instead is we're seeing an increase in maintaining staffing for the level of COVID we've had. So actually, we're not seeing any improvement really in terms of exceeding the block contract or being better than the block contract, but we are maintaining our position within it. We coming into the year end, we basically have two major issues. One is the cash. So we're sitting on a lot of money. Part of so £90 million. Most of that will disappear by moving to being paid a month in arrears, because at the moment we're paid at the beginning of the month, so that will reduce it by about 30 to 50 million pounds. But we also are being told not to worry about getting down to the 2 million requirement at year end. It doesn't seem to apply this year, so that's become less of an issue. We will have a higher balance than the standard year end figure. We are also going to slip some of the capital programme. So the report that I've shown you talks about changing the target by 5.7 million. In fact, it's in excess of 7.9, because what we're actually also doing is cancelling some requests for capital that are already in at the centre. So that is basically caused by not being able to get staff on the ground in the middle of COVID to be able to do some of that work before year end. I think it's a national issue, so we've all been asked to be more accurate in our forecast at month 9, and we've simply flagged that as an issue. There will be a similar level of capital available next year. We just don't know what the bidding process will be yet, and we're hoping to replace some of those or most of those projects in next year's process, so long as we understand what the process will be. Finally, I just want to talk briefly about the plan for next year. There is modelling going on to understand individual trusts' run rate. Sorry, before I go there, let me just finish off balance sheet at the end of the year. So we've been given a block contract. We initially were expecting to be in 6 million deficit by the end of the year. That's broadly in 2 chunks. One is projects that we had agreed with the ICS but were not part of the baseline from the previous year. So that's community funding for additional staff and the UTC, which were not accepted centrally by Treasury but were accepted by the ICS. Secondly, there was a chunk of funding that we lost from non-NHS funding routes, so things like the cafeteria, which was not initially recognised by Treasury, but there will be a process by month 12 to try to recognise some of that funding. So we're hoping that some of the 6 million deficit will actually be funded by year end. And finally, there has been an issue of recognising the staff are too busy to take their leave through to year end. So we're having to recognise some of the leave by the end of March. We're not sure that funding will actually be covered centrally, but nationally they have recognised that it is something that will have to be forecast on an individual trust level. So let me go back to how next year's funding will work. I've already mentioned that we're working on a run rate model to be used as the basis for, what's a reasonable target to set for individual trusts. What we will then be told is what element of support will we be given to hit next year's target. And hopefully once we've done those 2 things, we'll also then be given a relatively realistic savings target. I think it will start after the block contract completes. So, sometime at the end of June or the end of September, that's when we should go back to a more or less normal process. So I think I'll stop there if that's okay.
Thanks, Damien. Questions? Nikki.
Thanks, Chair. Thank you, Damien. That was a really helpful overview, which I think probably helped me in some ways more than the slides. I think my challenge for us going forward is being able to understand from what we see in these decks, the value for money position, because I think that's what I'm struggling to get my head around a little bit at the moment. And I think that's as a result of the way that the NHS is being funded centrally, and COVID and the complexities of understanding the impact of changes operationally as a result of COVID on our finances. But what I'd really love to see us look at and understand better going forward is value for money.
I think that's a really good question, Nikki, and I agree about the slides. I think the finance is moving a bit too quickly for these slides to catch up, so we actually need to improve our commentary on them. In terms of value for money, it is difficult to focus on that when people are clearly having to focus on, you know, how to react to COVID. In fact, to be honest, through December and January, we've had issues of having to manage pay rates to be able to make sure that we've got enough staff. And I think you've already seen that in Steve's presentation on the workforce, that, you know, it's a challenge to maintain enough staff coming through the door. In terms of getting to a next year's position, I think we need to have a non-COVID establishment, which will involve Steve and I initially, and then working with the whole of EDs, reviewing a start point establishment and reviewing all of the cost pressures that had been initially discussed through February and March last year. And, you know, we believe there's a total of about 330 staff that we need to understand what is the revised baseline that we need to start next year with. And that absolutely will involve comparing to, you know, what's a reasonable establishment and what's a reasonable benchmark across the NHS. We've recognised that's a starting point. We're beginning to set out those are the cases, but we haven't actually gone through the process yet. We do need to do it through February and March.
Thank you, Damon. To be clear, I completely recognise that this is a not for the last 2 months challenge, and also that when I say value for money, I don't mean cost saving.
Yeah, no, that's fair. I mean, yeah, I totally agree. And it is what I think might be helpful is if we are a bit better at bringing benchmarking in on the finance side, to show where we stand in comparison to other organisations. And frankly, part of that will need to be improved reporting on SLR, which I know we have put on the sidelines for the last year.
Thank you, Damien.
Thanks, Nikki. Jackie?
I think you've partly answered it, thanks, Damien. My question was really about cost pressures. So you've answered a bit about what we knew last year, but what about things coming forward this year? Have we got sight of them? I'm thinking particularly about the paper we had earlier on the Ockenden report. There are things in there that would require investment, which I don't think we can manage. So what's our process for sort of picking up the things that we're going to need next year that we haven't already identified?
So I picked up the same point when we were listening to Ockenden. I actually think there will need to be additional business cases on top of the 330. I mean, to be honest, the total staffing that Ockenden raised was not hugely significant. I mean, the whole point about when we had the medical response, that actually in total our additional hours are not far off the Ockenden requirement. It just needs to be a rebalance between 5 days and 7 days. But we do need to make sure the process is transparent. And yes, there may be other areas that we need to pick up other cost pressures.
And are they being flagged up now so that we get them in time?
So we will make sure there's a process to do so. I mean, we haven't actually started a budgeting process because our initial guidance was that the non-block process will be at least at least 3 months away. At a minimum, will take until June before we start that point. So the whole national process has been delayed.
Okay, thank you. Thanks.
Thanks.
Can I just come in on that bit? So I think, just Jackie, Richard's still running the business planning process. It's sitting behind all of this. So those sorts of things I would expect to be picked up in the usual way. And I think there are things that have changed, roles that have gone in. And I just had an email around having SALT, access to speech and language in ITU. I think we recognise some of our patient cohorts have changed, and we'll obviously have to reflect the long COVID, particularly in our community-based and some of our sort of acute-based services, at least sort of from an outpatients. But the answer, it will be picked up through business planning in a normal way, even though the timescales have moved.
Thanks, Jo. I mean, we can't spend what we haven't got, though. So reconciling that chunk of establishment 8 to 10 months stuff that Damien was describing earlier is massive, isn't it? It's absolutely massive. Paresh.
Thanks, Steve. Basically, Damien, 2 questions. I think you've answered partly the kind of the capital requirements going forward, and I think it's reassuring that we've got some bandwidth to kind of think clearly if the process has been delayed. In terms of cash, which is on the, I think on your cash at hand, as it were, are we actually expecting to? When are you trying to reconcile that to get to a reasonable number? Because it's about 90 million pounds. I don't know if that's something which is at risk, or is that something which is going to be reconciled by NHS E&I?
So that's why I specifically tried to bring it up, because our original target was to get to 2.1 million by year end.
Right.
And I've already raised that with Region, and the direct response was they don't believe that's a requirement for us to get down to that sort of level of number. Right. So the first thing that's going to happen is that we will move the date that we are paid, because at the moment we're paid at the beginning of the month to help with COVID and help with basically public sector debt payment targets of paying people within 30 days. And that will move to the end of the month, which will reduce it by at least 30 million. I suggested 40 to 50, but in fact, I think 30 is more accurate. So we will still be something like 60 million above where we should be. I think some of it, 10, 15 million, relates to capital processes that are still finishing through February and March. So again, that will take the figure down a bit. But there will still be an excess, and we will be carrying a bigger figure through this year end into next year. But like I say, that's the region has already confirmed that that's not going to be something that will be used to penalise us. It's just, in fact, what they have told us is they want cash to stay in the system to make sure we're paying suppliers on time. And we've had queries about whether whether there's anything else we can do to make sure that we're paying suppliers on time. So okay. Emphasis has definitely changed from previous years.
Thanks.
Thanks, Paresh. If there are no other questions, let's move on. Now, I'm mindful, as you all know, how obsessed I am with timekeeping. Well, this is probably my most dismal performance to date. I'm at least an hour behind where we should be, and we're now past the sort of finish time. And so a number of the items that we've got are for information or for approval. So we'll let's see how well we get on with the next couple of items. Richard.
Thank you, Chair. This may be the only paper on the agenda that doesn't actually mention COVID, proof that the NHS wider system never stops. This was discussed at F&I, so is here only for info, as Steve says. It's the formal ICS response to the NHS EI consultation about the future of integrated systems. We fully support this as an organisation. We were involved in forming the lines in response to the consultation. at the end of the paper, I try to draw it into the 4 bullet points that I think are relevant for our planning and strategy functions as we go forward. I think the main theme here is this evolution towards collaboration and integration that we're seeing is entirely consistent with the way that we're planning and also developing our strategies and documents as we move forward over the next 5-year period. We are continuing to deepen relationships both within the ICS as it gets more mature and also our partners and colleagues within the ICP in the local authorities, primary and community care organisations as well. So I think the broad general sense is we've fully supported it and it's where we're headed as well. So I'm happy to stop there and take questions.
Thanks, Richard. Joe, nothing you wanted to add to that? No. Questions, as Richard says, we have been through this already. Gone. Thank you. Review of corporate documents. Lynette.
Again, this is a fairly quick one. There are key governing documents. We've undertaken a thorough review this year. It's been through audit who support the adoption of the revision, so it's just here to ask the board to ratify the changes.
Questions or queries to Lynette? Gone. Approved. Lynette, thank you for the work on that, and also Damien. The annual charity report, that's also you, Lynette.
It is, and it's for the period ending March 20. The way it works is that the auditors finish the main trust audit and then they do the charitable funds afterwards. So it's quite old, but it captures the changes we've made in charitable funds. I mean, the big difference for the coming year is obviously the income that we're getting now through NHS Charities Together, and the money that has been raised nationally is being passed down to trust. So the report next year will highlight some of the really good things that we're spending that money on. I don't know if Karen wants to add anything because she's taken over the chair of the meeting.
Sorry, no comments. I know that we're trying to wrap up this this meeting. Yeah. Nothing further.
Great. Thanks very much, both. Information on the use of the trust seal. That takes us to questions from members of the public. We've had two sort of written submissions of questions, in detailed questions about discharge process and procedure, and information that we publicise about that I think people are taking on board, and then we've had some questions about the Ockenden review and some of the wider implications for obstetric services that fall out of that, and the and its connectivity or otherwise to the Building for the Future programme. So the plan is to do a detailed reply to both of those letters, and then that information will come to the next meeting. But I don't think we've had any other questions notified to us, and unless there's anything coming up, I suggest we move on. So thank you for that. That takes us to the end date of our next meeting, Tuesday the 9th of March. Thanks very much, everybody. On to the private part of the meeting. Do colleagues want to just go straight into that with a quick 5-minute comfort break rather than wait until 1 o'clock, or would you rather wait till 1? If there are no voices either way, I suggest then we just take 5 minutes, and well, I make it 22. So should we re-log in at about 1:45 and then we can get cracking? If that sounds all right. Good. Thank you very much, everybody. Thanks for everybody's contribution.